The committee will come to order. Good morning, and I'd like to thank each of our witnesses for voluntarily agreeing to appear before the committee this morning. Today's hearing is a continuation of the committee's larger effort to get to the root causes of why healthcare is so outrageously expensive for patients and why so many Americans lack access to healthcare. CEOs representing some of the nation's largest hospitals are before us. But let me be clear, the entire healthcare system, hospitals, insurance companies, drug manufacturers, pharmacy middlemen, all bear responsibility for the high cost patients face. First, hospitals, and in particular, the doctors, nurses, and medical professionals who work there treat vulnerable and do it with some of the most advanced medicine in the world. Our communities are better off with hospitals in them, but large health systems have taken advantage of that reality. The corporatization of American hospitals means that our local hospitals and physicians have been replaced by mega corporations that put quarterly earnings over quality care and grow larger simply for the sake of growing larger. Hospitals with more than 100 beds have a higher profit margin than Delta Airlines, Target, or Disney. Let me repeat that again. Hospitals with more than 100 beds have a higher profit margin than Delta Airlines, Disney, and Target. Turns out charging an arm and leg for healthcare is more lucrative than the happiest place on earth. When CEOs of some of the largest health insurance companies came before this committee earlier this year, they pointed the finger at hospitals as the culprit. This committee isn't interested in hearing about how the high prices your businesses charge are somehow someone else's fault. The blame game didn't work with insurers, and it won't work today with us. Simply put, hospitals are charging an insane amount for care. Hospital prices have skyrocketed 300% in just over 2 decades, more than any other sector of our economy. Not one sector was even close. Hospital consolidation and mergers that lead to ever-growing market power are fueling the borderline extortionary prices hospitals charge patients. Today, there are 4,500 hospitals, and 2,000 of them have undergone a merger since 2000. The result is that today, 90% of hospital beds are part of a health system. The pace and scale of mergers have led to market concentration that puts patients at the mercy of hospital empires. When hospitals have no competition, it's no wonder that the sky seems to be the limit for prices. A family in California was charged nearly $300,000 to treat their toddler's snake bite. $300,000 for a toddler's snake bite. A man in Florida had an emergency CT scan that the hospital billed for $13,000. A follow-up scan at a different location cost him only $79. Another Alabama woman was sued for the full cost of her appendix procedure plus interest, nearly $37,000. After faithfully paying the bill every month for 3 years, she told her husband that the burden of the lawsuit was so great that she wished she had passed away at the hospital rather than deal with the lawsuit. Those stories illustrate how these systems prey on patients who have few options for care in their time of need. Patients are not getting better for the higher prices either. Study after study found that hospital mergers are not generally associated with better health. In rural America, hospital mergers may sustain access in some communities, but I have seen firsthand how profit-seeking health systems view struggling rural hospitals as nothing more than a gateway to more patient referrals. It's no wonder rural Americans are sicker, have higher rates of chronic disease, and die earlier as a result. What's worse, a complex set of legal loopholes and open-ended taxpayer subsidies, manipulated by sophisticated hospitals, have become a key part of a business model that fuels ever larger systems, eliminates competition, and drives higher prices. Urban hospital chains double dip and classify themselves as both urban for higher wage index reimbursements and then reclassify as rural for another set of government benefits. That's absurd. One example that this committee has been focused on is the 10% of new residency slots that Congress set aside in 2020 for rural hospitals. Of the 120 slots allocated to rural hospitals, only 30 have actually gone to truly rural communities. In total, urban hospitals have taken 97% of all new residency slots, far more than Congress ever intended. It's unacceptable for large, wealthy urban hospitals to take what rightfully belongs to truly rural communities when those communities already suffer from lack of access to care. Regardless of a hospital's geography, we've seen health systems leverage payment differentials between hospital-owned clinics and independent physician offices direct more money to their corporate coffers. The higher reimbursement for hospital-owned clinics incentivizes consolidation and encourages hospitals to buy up more independent practices. It's no wonder today half of the U.S. physicians are employed by larger systems like hospitals. Unsurprisingly, this business practice also raises costs for patients receiving the exact same service. For example, an ultrasound costs $164 when provided by a physician. It costs $339 at a hospital outpatient department. A biopsy costs about $150 when performed by a physician. It costs $800 at a hospital outpatient department. Congress, including this committee, has taken efforts to right the wrong and ensure patients and taxpayers pay lower prices for the same service with the same quality. But every time we try to advance these so-called site-neutral policies, big hospitals, they fight us. They fight us tooth and nail. For-profit hospitals are legally required to put shareholders over patients, but so-called nonprofit hospitals rarely act much different. Tax-exempt hospitals deliver charity care that is consistently worth less than the tax breaks that they receive. These nonprofit hospitals receive a $28 billion tax break while only spending roughly $16 billion on charity care a year. The difference fuels a spending spree totally unrelated to providing health care like real estate investments, stadium naming rights, green energy initiatives, and political activism. Large hospital systems also manipulate the 340B drug pricing program to keep steep drug discounts for themselves instead of passing the savings to low-income patients. There is little evidence that the $290 billion in discounts given to hospitals under the 340B program since Obamacare was reinvested in patients. Even worse, there is evidence that hospital abuse of 340B actually directly led to increases in Obamacare premiums. Today, I expect we will hear how from these hospital executives, their opinion on how insurers and drug makers contribute to the unaffordable cost of health care. But this committee will be asking and expect answers to why hospital prices make up by far the largest share of the insurance premium increases that grew 3 times faster than earnings. This hearing is not the end of the road for our investigation into the unaffordable cost of health care. The American people are fed up with outrageous prices that seem artificially high. They're right. Hospital prices are unjustified. This committee will continue to fight to lower health care costs for working families. The first step is to get answers and expose the truth. And that's exactly why you are all here today. I'm pleased to recognize the ranking member, Mr. Neal, for his opening statement.
Thank you, Mr. Chairman. Rightfully feeling the heat of the public's anger, the majority is holding their third hearing on health care in as many weeks, all to deflect blame and responsibility. Families are not going to be fooled easily. This is about their tax bill. They know that right now it's wildly unpopular, and anything that can distract from the tax bill should be part of this conversation. Last year in America, the only real economic growth was in healthcare, for obvious and good reason. It's based on the innovation that is taking place. A reminder to colleagues, technology helps to drive the cost of healthcare. Let me give you an example. From Springfield to Worcester, Bay State Medical Center, UMass Memorial, a 40-mile stretch, and this morning the addition of Mercy Medical Center. 40 miles, more than 30,000 people get up and go to work every day. Who wouldn't want the teaching hospitals that we have across this country? And I'm proud of the fact that we expanded GME slots in a bipartisan manner recently. We will continue on the Democratic side to defend Medicare and Medicaid and the Affordable Care Act. An understanding that patients and families simply can't afford what's being offered to them as they watch profits for big corporations soar. But trying to lower the cost of health care, or perhaps a better description would be to manage it, is a challenge now, largely because of their tax bill. 37% of marketplace enrollees say they're cutting back on food and other necessities to afford health care coverage. We need to listen to them. I heard the argument that was offered just a couple of minutes ago. It's been my honor to represent the Sisters of Providence and the Mercy Medical Center through my lifetime. As I always point out, at 7 years old, I left my appendix there as well. Their achievements are remarkable. The Sisters of Providence, what they did for health care in Western Massachusetts, the Pioneer Valley, and indeed across America, is witness to the advances we've made in health care. Democrats know that it can be done, and we want further opportunities to make sure that health care in America is expanded to all members of the American family. Because of our fight, Medicare drug negotiations, and we capped out-of-pocket and insulin costs, expanded senior benefits, we delivered years of record enrollment, and now only 8.5% of the American people are without health insurance. Statistic: every child in Massachusetts has health insurance. 97% of the adults in Massachusetts have health insurance. 4 former governors and the current governor of Massachusetts, including Mitt Romney and Bill Weld, gathered but 2 weeks ago to celebrate our achievement. And you know what? Republican and Democrat, they all deserve credit for what they were willing to do when they had the opportunity. That's how you deliver for families. The president stamps his name on websites and hands out favors, but doesn't want to acknowledge the reality of how hard it is to manage health care costs. With the health care crisis, it's looming over millions of families. The fervor and attention that we've heard everywhere seldom addresses some of the root causes. Last year, we warned for months that their trillion-dollar tax cut bill was going to harm on the American health care system. They refused to acknowledge the questions that we raised. They ripped coverage from 15 million people and pushed hundreds of hospitals to the brink. And then they complain about the problem after it's their tax bill that's going to lead to these massive cuts. Health care is not a Democratic or Republican issue, it's an American issue. Their challenge based on rural health care is simple, and we want to help because many of us, myself included, we have rural health care challenges as well. I helped to reopen a hospital that was in desperate need of a rural, because of its rural setting, and today that hospital continues to deliver first-class health care. All of this is based upon they set the fire and now they're calling the fire department. There is no plan. I've been here for a long time. There has never been a Republican agreement on health care, simply the critique of what we've tried to do in the affirmative. They keep trying to convince people that it's about just the providers. It's about many of their policies as well. Families are paying more for everything because they have decided to go along with these ill-considered proposals. There's a different path. Democrats believe in the power of legislating for a fairer tomorrow. We stand up against those who try to cut taxes so that they can cut health care. We need to be talking about real solutions that bring costs down for workers and families, and that starts with reversing the harm of what they did in their tax bill. And you in the room today are going to be asked questions because of their policies as it relates to the tax bill. We should have a conversation about the tax bill, and then we can get on to some of the questions that perhaps are legitimately posed to all of you this morning. Thank you, Chairman.
Thank you, Ranking Member Neal. I will now introduce our witnesses. Mr. Sam Hazen is the Chief Executive Officer of HCA Healthcare. Mr. Wright Lassiter is President and Chief Executive Officer of CommonSpirit Health. And we have Dr. Brian Donley is President and Chief Executive Officer of New York-Presbyterian. And we have Dr. Michael Waldrum is Chief Executive Officer of ECU Health. We have Mr. Brad Woodhouse is President of Protect Our Care. Thank you all for joining us today. Your written statements will be made part of the hearing record, and you each have 5 minutes to deliver your remarks. Mr. Hazen, you may begin when you are ready.
Chairman Smith, Ranking Member Neal, and members of the committee, thank you for this opportunity to testify on healthcare affordability. I'm Sam Hazen, Chief Executive Officer of HCA Healthcare. I've been with the company for 43 years, and throughout my career, I've remained grounded in a simple belief. Healthcare is deeply personal and essential to everyone. I was raised in the coal mining communities of rural Kentucky, where access to care was often limited by distance, income, and infrastructure. Those experiences reaffirmed my commitment to high-quality health care, accessible and cost-effective for all. I'm honored to lead HCA Healthcare, a network of 190 hospitals and more than 2,500 sites of care. Last year, HCA served 47 million patients, including many in rural and underserved communities. Our hospitals operate 24 hours a day, 365 days a year. They are designed to operate under extreme conditions and remain open and responsive throughout public health emergencies like the COVID-19 pandemic, hurricanes such as Hurricane Helene, and other disruptions. We provide critical, life-saving services, and we care for every patient who comes through our emergency room doors, regardless of their ability to pay. Last year alone, we provided approximately $4.5 billion in uncompensated care, including charity care and financial assistance for uninsured patients. That number reflects commitment to our mission and the essential role our hospitals play in communities across the country. The reality of our system today is clear. Healthcare in this country has never been better nor more advanced, but it is also too expensive for too many people. Whether it is the price of a prescription, insurance premiums, or an unanticipated emergency room visit, the financial pressures associated with healthcare affect every American household. We ask this committee to consider 3 ways to address the affordability challenges. First, one of the most effective ways to address this challenge is to ensure stable and affordable health insurance coverage. When patients have reliable coverage, they have greater access and can seek care earlier, manage chronic conditions more effectively, and avoid costly emergency interventions. Coverage is an essential starting point, but coverage alone is not enough. Providers must also deliver care more efficiently, with higher quality and greater consistency. At HCA Healthcare, we are investing in technologies, workforce development, and care delivery models that improve outcomes, expand access, and reduce unnecessary costs. We are working to give patients better information about the cost of their care while recognizing that true transparency requires coordination across the entire system. Second, fair competition matters too. When providers compete on quality, service, and access, it drives better patient care and lowers costs. Certificate of need laws, originally intended to control costs, now do the opposite, limiting competition, constraining supply, and increasing prices. Revisiting these laws would encourage innovation and improve access, especially in underserved areas. Third, we also see firsthand the toll of administrative complexity. Insured patients and providers routinely face barriers, including prior authorization and payment disputes such as care denials and underpayments. These frictions translate directly into delayed diagnosis, reduced access, and higher costs. HCA is attempting to work with payers to address some of these challenges, and I am encouraged by early progress. At the same time, hospitals must comply with hundreds of overlapping and sometimes conflicting federal and state requirements. While these regulations promote quality, their volume can often create inefficiencies that divert time and resources away from the patients they are meant to protect. In conclusion, the best way to improve healthcare in the United States is for all participants to work together toward the shared goal of building a system that serves everyone. At HCA Healthcare, we are committed to playing an active role in that effort. Thank you again. I look forward to our discussion today.
Thank you. Mr. Lassiter, you are now recognized.
Chairman Smith, Ranking Member Neal, and members of the committee, thank you for the opportunity to testify on an issue that affects every individual, healthcare affordability. I'm Wright Lassiter, President and CEO of CommonSpirit Health. I'm proud to be here representing our Catholic nonprofit health system that operates 158 hospitals across 24 states, including 41 rural facilities, and among them 29 critical access hospitals, making us one of the nation's largest rural healthcare providers. Guided by a mission to serve all, especially those who are most vulnerable, we provide 25 million patient visits each year. We're one of the nation's largest Medicaid providers, and we deliver 1 out of every 42 babies in this country. Health systems play a critical role in affordability by integrating hospitals, clinicians, and care teams to reduce duplication and improve outcomes. Health systems support information technology, electronic health records, and data integration. We also create operational efficiencies, improve purchasing and contracting so more resources can flow to patient care. That is especially important in rural and underserved communities where standalone hospitals often lack the ability to spread fixed costs, invest in innovation and technology, or sustain essential services when reimbursement falls short and expenses rise. Since forming in 2019, CommonSpirit has reduced operating costs by $3 billion through scale, efficiency, and innovation. We have also used that scale to strengthen quality and safety across our health system. CommonSpirit has exceeded the national average for CMS hospital quality star ratings for 5 straight years. We provide more than $5 billion in community benefit annually, including the unpaid costs of governmental programs. We are consistently using new approaches to improve care and strengthen operations. For instance, our sepsis surveillance program helped save more than 3,600 lives last year and reduced stays in the ICU by more than 33 hours per patient. Our AI initiatives generate more than $100 million in savings on an annual basis by improving efficiency and reducing administrative burden. Our virtual integrated care program provides real-time remote support to nursing teams, helping us address workforce shortages and support high-quality care. Virtual nurses help safely discharge more than 16,000 patients, freeing up bedside nurses from thousands of hours of paperwork. Today, healthcare affordability is being strained by 4 powerful forces: labor, rising supply and technology costs, payer behavior, and regulatory burden. Labor alone has risen more than 20% in the last 5 years and now represents more than 54% of our operating expenses. Prices of pharmaceuticals, medical supplies, and advanced technologies each grew by more than 10% last year. For example, Our spending on IV fluids has increased by more than 14% since 2024. Payer pressure is also intensifying. Billing for Medicare Advantage patients is about 25% more expensive than for traditional Medicare patients, pulling staff, time, and resources away from patient care. Commercial insurers increasingly deny claims or underpay for services provided. Medicare Advantage plans are the most challenging. Today, we have $4.3 billion in unpaid Medicare Advantage claims, with nearly $1 billion of that being more than 150 days past due for care that CommonSpirit has delivered to patients in communities that you represent. Medicare and Medicaid represent nearly 70% of our patient volume, yet Medicare reimburses approximately 80% of our costs to care for those patients. Medicaid underpayment is also an access issue, especially in rural communities that typically have higher rates of unemployment and poverty. When public coverage falls short and more people become uninsured, uncompensated care rises, pressures on hospitals intensify, and access becomes harder to sustain. Regulatory burden for CommonSpirit adds another $1 billion of costs to our expenses on an annual basis. Those are resources that otherwise could be placed directly towards patient care. We cannot solve affordability alone. Hospitals, providers, payers, and the government must work together to ensure timely payment for care delivered, adequate reimbursement from Medicare and Medicaid, relief from unnecessary regulatory burden, and stronger accountability for health plans. Thank you for the opportunity to be part of the discussion today.
Thank you. Mr. Donley, you are now recognized.
Good morning, Chairman Smith, Ranking Member Neal, and distinguished committee members. My name is Brian Donley, and I serve as President and CEO of York-Presbyterian. I'm also a doctor with more than 20 years of experience caring for patients. I joined York-Presbyterian 3 years ago as the Chief Operating Officer, and I assumed the CEO role 12 weeks ago. I was raised in Pittsburgh, and caring for people was a central part of my upbringing. My mother is a nurse, and my father was a community pharmacist. They instilled in me that healthcare is grounded in empathy, respect, and the sacred trust between a patient and a caregiver. I come before you today as both a doctor and a health system leader, deeply focused on compassionate, high-quality, accessible, and affordable care. I want to begin by acknowledging what York-Presbyterian patients and patients across this country are experiencing. The cost of care is a real and growing concern. I recognize that hospitals are one part of a broader healthcare system that contributes to these costs, and I take that responsibility seriously. York-Presbyterian is committed to working with policymakers, payers, pharmaceutical companies, and the many other healthcare stakeholders to find solutions that make care more affordable and more accessible to Americans. York-Presbyterian is one of the nation's oldest academic systems. With 10 hospitals, nearly 45,000 employees, and more than 2 million patients served annually. We are among the largest providers of care to Medicaid patients in New York, and we serve patients from all 50 states. We care for some of the most complex and vulnerable individuals in the country. In fact, our children's hospital provides some of the highest acuity of care of any children's hospital in the nation. For 250 years, our approach has been grounded in an enduring set of commitments, including putting our patients first, investing in our people, and maintaining deep connections to the communities that we serve. Our mission is straightforward: to provide the highest quality of care to all patients, regardless of their ability to pay. But delivering on that mission comes with real financial pressures. We are facing substantial cost pressures, such as labor, supplies, and pharmaceuticals, with drug costs alone rising by 25%. Compounding these challenges, government payers do not reimburse the full cost of care. We also face growing administrative burdens driven by the current insurance environment that creates unnecessary cost and frustration for both patients and providers. In response, we are focused on 4 key areas to make care more affordable for our patients. First, we are doubling down on high-quality care, because when care is better, it's not only do patients do better, but care is less costly. That means fewer readmissions, fewer hospital-acquired infections, and fewer complications. Second, when it's right for the patient, we are shifting care to lower-cost settings through hospital-at-home programs, virtual nursing, ambulatory care, and telehealth. Third, we are using technology to drive efficiency by cutting waste, improving productivity, and reducing administrative burden, especially around insurance denials and prior authorization. And fourth, we are investing in our communities to reduce chronic disease. We are working with partners on programs that improve health upstream and therefore help prevent avoidable hospitalizations. Beyond patient care, York-Presbyterian provides significant community benefit. Last year alone, this totaled $2.4 billion, more than 20% of our operating expenses, supporting important community-based services and school-based health centers that serve 28,000 children in New York City public schools. These investments are core to our mission, but they rely on a sustainable financial foundation. Affordability in healthcare requires a shared responsibility of all stakeholders. The 45,000 dedicated people of New York-Presbyterian are committed to caring for patients with compassion, to advancing treatments that save lives, and to strengthening the communities we serve. We stand ready to work together to make high-quality healthcare more accessible and more affordable for all Americans. I appreciate this opportunity to engage in a meaningful discussion so that we, together, can be better for the patients and communities that we care for and that you represent. Thank you.
Thank you, Dr. Waldrum. You are now recognized.
Good morning, Chairman Smith, Ranking Member Neal, and members of the committee. My name is Mike Waldrum. I'm a critical care physician and Chief Executive Officer of ECU Health, a nonprofit, mission-driven healthcare system located in rural eastern North Carolina. I'm honored to offer testimony before you today on healthcare affordability and share the realities of sustaining access in our region. The barriers facing rural health systems are real and structural. I look forward to working with this committee on solutions that strengthen access and affordability to ensure people living in rural communities are not disadvantaged simply because of where they live. My hope is that this testimony shines a light on ECU Health's experience on delivering care to 1.4 million people living in a vast rural region about the size of Maryland. I have dedicated my life to helping people in need and in places where I can make the greatest impact, taking care of the sickest and most complex patients. I moved to Eastern North Carolina specifically to work on the issues that rural communities face, and that's why I'm here with you today. I recognize and I appreciate the monumental task before Congress to address rising healthcare costs while protecting access to care. But the challenges we continue to mount. It is urgent we go beyond a one-size-fits-all solution to solve the rural health care crisis. I have trained and worked in some of the nation's most prestigious healthcare organizations. I have also seen the other side, patients who lack access to even basic healthcare needs. I've witnessed the damage to communities and hardworking rural citizens when access to care diminishes as resources increasingly are concentrated in urban markets. I've experienced how healthcare operates under very different conditions and constraints, and how those differences shape healthcare access, affordability, and outcomes. This is the story of two healthcare markets in our country, urban and rural. The realities of rural healthcare are complex, sicker, older populations, flat or declining growth, and patients spread across vast, challenging landscapes. In Eastern North Carolina, if Eastern North Carolina were its own state, it would rank among the country's poorest and sickest. These realities, coupled with regulatory pressures, have driven hospitals and clinic closures. Consolidation in our market is not driven by preference. It is how we survive. As some exit and others enter with profit-driven agendas, systems like ECU Health are left to serve as the safety net. The result is reduced access, worsening outcomes, and increasing costs. These dynamics are not theoretical. This is the reality of the rural health care crisis in America. Despite the persistent headwinds, ECU Health has sustained access across our 29-county region through a hub-and-spoke model where our community hospitals are supported by the resources generated by our academic medical center. We have grown into a 9-hospital system with more than 1,200 providers, not in pursuit of scale, but out of community necessity. We are transforming our rural academic regional system of care to lower costs, sustain and grow access to essential services, and support the economic vitality of rural communities. We have made significant progress, but we have much work to do. As this committee considers federal health care policy, I encourage you to design solutions that are tailored to the 66 million people living in rural communities. Policies that do not account for the differences between urban and rural markets risk leaving those communities behind. We know this work cannot be done alone. We stand ready to partner with you on a solution. Thank you.
Thank you, Mr. Woodhouse. You are now recognized.
Thank you so much, Chairman Smith, Ranking Member Neal, and distinguished members of the committee. Thank you for the opportunity to testify today. My name is Brad Woodhouse. I'm the president of Protect Our Care. Our mission is to make high-quality, affordable health care a right and not a privilege for everyone. I'm here today because that mission is under threat. We are facing a health care affordability crisis. H.R. 1 made the largest cuts to health care in American history to fund tax breaks for billionaires and big corporations. No amount of finger-pointing can distract from the reality that H.R. 1 cut $1 trillion from Medicaid and the Affordable Care Act, which will rip life-saving coverage away from 15 million Americans, including seniors, children, and people with disabilities. That same bill handed out $730 billion in tax breaks to corporations and $890 billion in tax breaks to millionaires. Today, nearly a year later, roughly 4 million people have already lost their health care, but that's not all. Costs are skyrocketing for millions of Americans. Families are being forced to make impossible choices between paying for groceries and seeing a doctor. And small businesses are closing their doors. The ripple effect of these cuts has catapulted health care to the #1 issue in America. Recent Gallup poll showed that the availability and affordability of health care topped the chart of American worries about key issues, ranking higher than the economy and inflation. One of the biggest impacts of H.R. 1 is on our nation's hospitals. Following the passage of H.R. 1, Protect Our Care launched a Hospital Crisis Watch. It's an interactive map on our website that tracks hospitals, nursing homes, and other care facilities that have shut down, cut services, or are at risk due to H.R. 1's devastating cuts to health care. When a hospital closes its doors, everyone feels the pain. Patients have to travel further for care, families face longer wait times in overwhelmed emergency rooms, moms are left without maternity care, putting their lives and their babies' lives at risk, and entire communities will be left without access to care while CEOs and billionaires get another tax cut. Here's some key numbers from our Hospital Crisis Watch tracker. As of this morning, 889 hospitals, clinics, and nursing homes have either shut down, cut services, or are at risk of doing so since Congress passed H.R. 1. That includes nearly 60 hospital wards which have shuttered, including 30 maternity wards. Over 240 clinics have been forced to close, and over 400 hospitals remain at deep risk of closure or cuts. And everyone is paying the price because Congress put tax cuts for billionaires and big corporations above the needs of working people. When a hospital closes, costs rise by an estimated $500 per hospital stay at a nearby facility. This means higher health insurance premiums for everyone, regardless of where they get their coverage. As the 6th largest employer in the country, hospitals are key economic drivers, especially in rural America. But because Congress passed the largest cuts to health care in history, nearly 500,000 healthcare workers could lose their jobs. Communities are so desperate to save their local hospitals that counties and states from California to Alabama are raising property taxes to stop their hospitals from closing. As our map shows, the consequences of H.R. 1 are already playing out, and the things will only get worse in the years to come as these cuts come into full force. Here are a few stories illustrating the impact of the cuts and closures that have occurred since H.R. 1 passed. In Nebraska's 3rd Congressional District, a nursing home, a primary care clinic, and a critical dialysis unit were all forced to shutter, and 5 hospitals remain at risk of cuts or closures. A rancher in that district from Hay Springs is now spending 9 hours each week driving to and from Scottsbluff for his dialysis. In New York's 24th Congressional District, a dialysis unit was closed there. Now patients are scrambling to find a new place to get life-saving treatment. 5 hospitals in that district are also at risk of closure or cuts. In Ohio's 7th Congressional District, 5 clinics were forced to close due to these Medicaid cuts, leaving families with fewer options for care. Look, Protect Our Care has been crisscrossing America to sound the alarm on how these cuts are pushing hospitals to the brink, stripping care from communities, and putting lives at risk. Every day presents a chance to stop this healthcare crisis, but this administration has not lifted a finger to deliver relief to the American people. Congress should be focused on making healthcare more affordable and accessible, not ripping it away to give tax breaks to the rich. Thank you for the opportunity to be here, and I look forward to your questions.
Thank you all again for being here. I'll now begin the question and answer session with the Vice Chairman of our Health Subcommittee, Mr. Buchanan.
Thank you, Mr. Chairman, and I want to thank all of our witnesses. I want to shift gears a little bit in my 5 minutes and get your input, so that's kind of where I'm going to go. Bill Frist was here in front of us. We had a hearing. Bill Frist was here, and he talked about the landscape of obesity and related diseases that defined America. Then he said the surest and safest way to maximize your health is food as medicine. So he took for an hour or two talk about food as medicine. So I believe personally myself, and something we didn't talk about, nobody brought it up, but I'm sure we're focused on the other stuff. I believe that prevention and eating real food is the key to making health care more affordable. The U.S. is spending $5.3 trillion on health care, yet we're getting sicker as a nation. 6 in 10 Americans, 95% of Medicare beneficiaries, have at least one chronic disease. Roughly half of the adult population is obese, and when you look at it, the thing that makes me sad, we have 10 grandkids, but children, 20% of the obesity for kids are obese, 20%, and 30, young ones that would serve maybe in the military, 20 to 30, basically there's 30% are obese. I believe the problem stems from unhealthy and ultra-processed food. We must prioritize prevention. In other words, don't get sick in the first place to the extent we can. They said that if you have cancer and you catch it early and you do it, there's a good chance you're not going to have to deal with it. We must prioritize prevention as a key to reversing trends in heart disease, obesity, and diabetes. Hospitals not only treat people that are sick, but hospitals can and should take more time to make sure that what we're doing is the right thing long term. I want to applaud HHS, its efforts to create a new food pyramid, which prioritizes real food and makes hospitals' food healthier pledge. So I guess one of the things I'd like to ask all of you, have you taken a look at that pledge and does that make sense to you in terms of signing on? If you haven't signed on, will you sign on? Anybody that's taken the pledge, go ahead. Yeah, go ahead. Did you want to?
Yes, Vice Chairman Buchanan, so thank you for the comments. I would say that at CommonSpirit Health, we follow the Make Hospital Food Healthier pledge that HHS has put forward. We certainly believe in food as medicine as part of what we do to serve communities. In a number of communities where we serve, where there are food deserts, our facilities offer food pantries with fresh produce to provide those resources for those who don't have access. And so we certainly support the notion of healthy food, sir.
Mr. Donley, go ahead. Just what's your thoughts on that? I know I touched base with you. We talked about it a little bit, but I think it's huge.
Yes, thank you, Congressman, for your advocacy of living healthier lifestyles. It is one of the 4 things that we're working on in order to develop more affordable care. Strongly agree with you. And what we do is we're embedded in our communities. We work with our schools. We work with faith-based organizations. We work with nonprofit organizations around teaching healthier lifestyles, around teaching proper nutrition, around teaching healthy exercise. We work with our schools so that we can reach people at a younger age, because then the impact is longer lasting. They also work with their families.
Do you find that statistic, 20% of children are obese? Is that legitimate? Is that a number? That's the number I've heard. It's outrageous to me.
I don't know the exact statistic, but I know it's unacceptable, and every one of us should understand the role that we can play, and especially in healthcare, in a preventive way, because that decreases.
You guys are in the health business. We've got to get people healthy. Mr. Hazen, you want to give us your thoughts on that?
Well, I think anything, Congressman, that we can do to make people healthier will drive down costs for sure in the system. Just to give you one perspective, one of the drivers we've seen in our organization over the last 10 years is the complexity of the patients we have to deal with have numerous complications, comorbidities, obesity, diabetes, and so forth, and that forces more resource consumption.
I've only got a couple of seconds. Let me just say, I hear what you're saying. I want to try to help people be able to not get to that level. Someone said that if you have a heart attack, 50% of people don't live to see the next day. How about not having a heart attack in the first place? I think a lot of it's diet related, obviously movement, exercise as well, but that's kind of where I'm coming from. Yeah. We all have a responsibility. We're spending $5.5 trillion, basically $5.3 trillion in healthcare, and we're getting sicker. That's got to change, and change now. Thank you. I yield back.
Mr. Neal.
Thanks, Chairman. So let me acknowledge, just as I begin my questioning, the hardworking people who are part of this debate today, and that's members from 32 BJ SEIU from New England, who do a great job for all of us every day. And they understand what's going to happen with the impact of the cuts that are coming to Medicaid and to the ACA. They, like all members of the American family, are going to be facing the reality of what the tax bill that the Republicans embraced will do. America needs 86,000 new doctors. That's where graduate medical education comes in. That's where our academic centers come in. Every member of Congress ought to spend a Friday night or a Saturday night in an emergency room to see what it's really like for people who arrive there without a lot of answers, or perhaps that mom with a sick child. Do members understand what disproportionate share hospitals do? The testimony was exceptional today. It's not about rural versus urban. It's about making sure that when a rural hospital perhaps can't solve a certain problem, that they might move to an urban setting, or vice versa. Whereas noted here, with perhaps lower cost, it could happen. But people that show up in an emergency room on a Friday, Saturday night, they are unlikely to be too concerned about cost, and that's where advocacy comes in. These cuts that are being proposed don't make any sense. So let me say something about Bay State Medical Center again and Mass General Hospital. If you've got a sick child anywhere in America, I could recommend those hospitals to you. The work that they perform is extraordinary. Do members of the committee and Congress understand what technology has done to driving healthcare costs? Does anybody know what the cost is of a linear accelerator? It's top-notch healthcare. And again, the argument today is we should justify these tax cuts by denying people basic health care at our hospitals? This committee, as I noted in my opening statement, on a bipartisan basis, we expanded graduate medical education opportunities to help address the issue of a shortage of 86,000 doctors across America. I am proud of what we've done over many years here by incrementally improving the opportunities for people as it relates to health care. But let's also be honest. The emergency room is a bad place to have to get health care. That's just the reality. And getting out front on a lot of these issues could be very helpful to, again, the American family. Your testimony has been right on target. So let me ask you, Mr. Woodhouse, tell us about the 15 million Americans who are about to be denied health care because of the tax cut bill that our Republican colleagues have embraced.
Sure. Thank you, Chairman Neal. And as you know, Protect Our Care is all across the country. And we're collecting stories constantly about people who are facing these challenges. We've heard from farmers in Iowa, small business owners in Virginia, caregivers in Michigan who have had their health care jeopardized by these cuts, in some cases particularly by the elimination of the tax credits. We collected hundreds of stories of working Americans who are losing health care or making sacrifices to pay what is now double, triple, and quadruple their health care premiums. I'll give you two stories. Janine Shackelford is a realtor in Youngstown, Ohio, who is was self-employed because the Affordable Care Act made her health insurance affordable, around $200 a month. In 2026, her premiums jumped to $900 a month, more than her mortgage. She could no longer afford it, and she's been forced to quit her job, which was self-employed, to try to find a job with insurance. Rena Bumbray Graves is a home care worker in Woodbridge, Virginia, who cares for two relatives with disabilities. She and her husband's premiums spiked from $544 a month to over $1,300 a month. And you know what? They're just not going with health care right now. They simply can't afford it. So those are two stories, but there are dozens and dozens and actually hundreds that we've collected that are just like that.
Thank you. So I hope that all members of the committee might consider, perhaps on a Friday or Saturday night, getting in an ambulance and making a patient run to see what it's like for senior citizens, perhaps where one is confused, but there is a real emergency. I think that we're misunderstanding the realities of what a breast cancer imaging machine might cost, what a linear accelerator might cost, what the best doctors in the world and nurses and healthcare professionals might cost. This could be addressed in a bipartisan manner, absent what the big bill did. And I yield back my time.
In January, this committee heard from the CEOs of the biggest health insurance companies. When asked what is driving up premiums for Americans, they pointed their finger at all of you. The hospitals. They have a point. The data clearly shows that hospital prices have risen faster than any other part of the economy, nearly 300% in just the past 20 years. And 1/3 of all U.S. health spending is on hospital care, more than any other part of the system, $1.6 trillion a year. However, hospitals and healthcare providers are the ones delivering medical services. I believe every member of Congress has been in an emergency room with a family member or a friend. So I don't think we have to address that. I think we all understand health care. Let's start with a show of hands. I'm going to ask a few different questions. Raise your hand if you agree that insurance providers are too big and are taking advantage of healthcare providers. It's for all of you. So 2 of you agree with that. Raise your hand if your hospital or an association that you are a member of lobbied to expand the expanded Obamacare tax credits that would have funneled $400 billion directly into the pockets of those same insurers. Only 1 of you. So 2 of you. You just have to raise your hand at the same time when I ask it. If you don't agree with the statement, don't raise your hand, but if you agree with the statement, raise your hand. It's pretty simple. So, just one. Mr. Hazen, thank you for being honest. This is one of the problems with healthcare. Hospitals, they blame insurers and drug companies. Democrats blame Republicans. Republicans blame Democrats. Insurers blame hospitals and drug companies. Drug companies blame PBMs and hospitals. But when it comes to fixing the system, the only thing you all agree on, really, is that it's some other people, other issues that's the increase. Raise your hands if you believe hospitals deserve to be paid more than independent physician practices for the exact same service. Thank you. This is another serious problem. Hospital empires are being financially incentivized to reduce access in rural communities and are working to game the systems to get the highest possible reimbursements. But when you talk about policies that create competition and more access for patients, you get vocal opposition from you and your Washington representatives. Medicare relies on outdated and misaligned reimbursements that pay more for the same services delivered in a hospital clinic than an independent physician's office. Let's talk about what that means for a senior living in my district in Festus, Missouri. Raise your hand if her Medicare bill for a standard X-ray image would be higher in your hospital-owned clinic than if she went to her local doctor's office. Right? Raise your hand if your hospital makes more revenue for that service than the doctor down the street. Now raise your hand if you would support legislation that equalizes such payments at the doctor rate so folks can have more access to care and a bill that they can afford. Unfortunate. A troubling development in Medicare over the last decade has been sophisticated. Wealthy hospitals and health systems in urban cities leveraging a loophole to classify themselves as rural, even when they treat few, if any, rural patients. They do this to reap a windfall of benefits intended to support truly rural hospitals, including higher residency training funding and easier access to heavily discounted drugs under the 340B program, a highly lucrative revenue stream for hospitals. Rural classifications have risen from only 3 hospitals in 2017 to 425 by 2023, a 14,000% increase. All of this is the expense of truly rural communities. Dr. Donley, as you know, I represent one of the most rural districts in Congress, made up of farmers and ranchers who drive up to more than an hour for basic care at a rural facility that is reimbursed 4% lower than the national average. You have chosen to self-classify your flagship hospital in your New York-Presbyterian system as rural. Meanwhile, you get reimbursed 40% higher than the national average. To be clear, there are 0 farms there in Midtown Manhattan. I've been there. And no crops are growing on East 68th Street next to your supposedly rural hospital campus, correct?
That's correct.
So how exactly do you justify this clear abuse of the Medicare program where big city hospitals drain the Medicare trust fund of billions of dollars meant to support truly rural independent hospitals?
First of all, I'd like to thank you, Chairman, for your advocacy for rural hospitals. As a physician, I can tell you that rural hospitals are critical to healthcare in this country, and it's important that all of us concentrate to make them strong for the health of this nation. We are not a geographically rural hospital, but under CMS, we are designated a rural referral center. We are proud of the role that we play for rural hospitals. We see thousands of patients referred from rural hospitals when those patients and those doctors have nowhere to turn. And We're proud to take care of those patients. We're also proud of the 2,500 residents that we train. 65% of them leave NYP and go across the nation, including into rural America, to take care of patients.
How many rural patients do you refer?
We received referrals of, we saw 8,000 patient visits.
And how many patients visits did you have all of last year?
We had 2 million patients that we took care of. 8,000 doesn't seem a lot, but I'll tell you, when you're one of those patients and you're one of those doctors and you have nowhere to turn for a really complex problem, I think those are some of the most gratifying patients that we have.
So do you think just because you served 8,000 patients out of 2 million that were rural, that you should get the benefits of a rural independent hospital in Salem, Missouri that's barely struggling to keep their doors open?
I think under the rules and regulations of CMS, we meet the qualifications to be designated a rural referral center.
Do you think those rules should be changed?
I think if we look at opportunities to change those rules, we have to make sure that they balance the health of rural hospitals, but also the importance of urban hospitals that support rural health care.
I'm just reminded by what healthcare professionals have told me all the time, is that healthcare follows the dollar. We're seeing that today just unfold, that healthcare follows the dollar, and people in rural areas have a lower life expectancy rate than those in rural areas because the dollar's not going into rural areas and they are dying. People are dying in rural areas because they're not getting access of rural health care. This is not urban versus rural. This is about every single American having access to health care. But they don't. They don't. And the only way we will fix the system is if all the entities, the insurers, the hospitals, the drug manufacturers, the Democrats, the Republicans, will come together and stop talking about other bills that have passed and focus on new bills that need to pass. Until we get to that point, we're only going to see healthcare continue to skyrocket, and healthcare companies, insurers, hospitals continue to have large profit margins. We saw United Healthcare have the highest earnings ever reported last quarter. That is a broken system, which we have to address. And so I'm done. Mr. Doggett.
Well, thank you, Mr. Chairman. There are a number of the concerns that you've raised this morning that I share. I think hospital costs are high and they're soaring higher. The problem is when you talk about new bills that need to pass, the bills you propose to address any of these problems don't get to the core of the problem. The leading bill that this administration pushed was to give more price disclosure information, which is unlikely to have a significant impact on desperate sick people seeking care. The site neutrality provision may have some merit. It's a fairly narrow focus. And at the same time, you talk about new bills that need to pass, where there are actions this committee could take that would make a real difference, you obstruct and block consideration of the legislation. That's why I agree with Mr. Neal that this is more a deflection hearing than a hospital hearing. Let's talk about 3 areas that are being blocked and obstructed that could make a real difference in accord with the testimony we've heard this morning. The first one is stable coverage. This is a committee and an administration that has done more to take away health care coverage from American people than any in American history. And what happens is, as Mr. Hazen indicated, is that when people don't have stable coverage, when their Medicaid's taken away, when they can't afford their marketplace plan, they don't get treatment when they need it. And so they show up in the emergency room. And some of those folks are going to show up in the emergency room and they don't have anything to pay the bill. And the hospital can't pay its nurses and physicians and its staff and its administrative costs with an IOU. It needs to pass those costs along to all the rest of us who have decent insurance plans. The lack of stable coverage that is the direct responsibility of this committee and the Trump administration in those cuts is having a huge impact on hospital costs and on costs that are borne by all of us. The second area where this committee could do something but refuses to act and obstructs those of us who want to act is with regard to pharmaceuticals. The Trump RX is as phony as a diploma from the failed Trump University. This committee is under a stranglehold by Big Pharma. It won't even hold a hearing on the actions of pharmaceutical manufacturers. And yet, as Dr. Donley has pointed out, and I'm sure it's true in some of the other systems, in 1 year, the drug cost at his hospital went up over 25%. You cannot deal with high hospital costs unless you look at pharmaceutical cost, and this committee refuses to do it. And the third area where we can't get action is Medicare Advantage. And we've had testimony this morning about what a difference that makes. Let me ask you, Mr. Lassiter, a little more about that. I've authored the Bipartisan Prompt and Fair Pay. And when I talk about Republicans, I'm not talking about all Republicans. Dr. Murphy, Dr. Harris, Chuck Edwards, Congressman Thompson have all joined in that effort to get prompt and fair pay. You mentioned that at your hospital, how many $1 billion is it that you have in bills that Medicare Advantage has not paid?
Thank you, Congressman Doggett. We have $4.3 billion in
$4.3 billion
unpaid claims for Medicare Advantage.
Well, our bill is one that is focused on getting prompt and fair payment. We learned in prior hearings that sometimes Medicare Advantage doesn't even pay the cost of traditional Medicare in reimbursing for health care services. You mentioned your support for this prompt and fair pay bill that we've introduced on a bipartisan basis in your written testimony. Can you describe some of the difficulties that you've been having there?
Yes, sir. I would say yes. I would say thank you to you and to Representative Arrington for sponsoring the Prompt Pay Act bill. We are supportive. As I mentioned in my testimony, we have significant unpaid claims, and we have claims about $1 billion that are over 150 days old. I would say that for Medicare Advantage, it costs us 25% more to process a Medicare Advantage claim than it does traditional Medicare. And we also suffer, as you indicated, from the fact that the reimbursement level for Medicare Advantage patients oftentimes does not cover the full cost of care. That is correct, sir. Thank you.
Thank you.
Mr. Smith.
Thank you, Mr. Chairman, and thank you to our witnesses today. I know that I don't have to announce the purpose we're having this hearing today, but certainly the numbers do speak for themselves. I want to first touch on Mr. Woodhouse's testimony where he alleges that the passage of the One Big Beautiful Bill caused a nursing home in my district to close. Now that nursing home, CHI Health, St. Francis Skilled Nursing Facility in Grand Island, is owned by CommonSpirit. Incidentally, we've got the CEO of CommonSpirit here, Mr. Lassiter. Thank you for being here. Did the passage of the One Big Beautiful Bill that actually cause that skilled nursing facility to close?
Good morning, Representative Smith. Thank you for the question. That facility closed because of extremely low volume. We operate a number of skilled nursing facilities in multiple communities. We felt that we could provide the access to that skilled nursing service within the hospital and not within a separate skilled nursing facility. And so it was closed because there was not sufficient volume to support the cost structure of an independent skilled nursing facility.
Not because of the passage of the bill that was referenced.
I'm not commenting specifically on his commentary. I'm giving you my answer as to why that facility closed.
Okay, so perhaps there's a few facts on the ground that were omitted in the previous reference, and I understand debates that we have across America. I would hope that we would meet the expectations of the American people, and that's to have a good conversation, a back and forth, a thoughtful conversation on how we can address many of the challenges that we face. And so, that certainly leads me to speak more directly in terms of how hospital prices are set And why is the price of hospital services so high? How are prices determined? And obviously, to state the obvious, if the price of health care is high, the cost borne by the payer of health care is going to be high. If providers charge high prices, insurance companies must set premiums and deductibles accordingly. The average cost to insure a family of 4 in the U.S. is a surreal $27,000 per year. Just average family of 4, average cost. And so why does insurance cost so much? High prices lead, obviously, to high premiums. If you look at the chart behind me, you can see that the price of hospital services has risen faster than any other area of the economy since 2001. It's not even close. Since 2001, average hourly wages have risen 131%, pretty decent. Medical care services have risen 147%. The price of hospital services has risen 281%. Again, 281%, far greater than any other area of the economy. To be clear, there are issues in the health insurance industry, but how are insurers supposed to keep premiums down if the cost of hospital services go up 281% in 25 years? Thank you. Mr. Hazen, I'm going to direct the question to you since your written testimony certainly references the need for affordable insurance coverage. HCA charges commercial insurers more than 3 times the Medicare rate. How can insurers lower premiums if HCA charges 3 times the Medicare rate?
Congressman, thank you for sharing the chart, and thank you for that question. We believe 3 drivers, let me start with that, with respect to the hospital costs are evident, at least in our markets. One is demand is growing significantly. In the last 10 years, we've seen 2.5% per year growth in demand for our services and services in general for healthcare. The second thing I would tell you is the complexity of care, which is connected to that chart, I believe, has grown significantly also. So the patients we're taking care of are more complex and require more services.
So technology, new methods, new research, that's not buying any savings?
Well, I think it's the patient population, Congressman. They're sicker. And we talked about that earlier with complications, obesity, diabetes, and so forth.
Given the fact that I've got limited time here, I do want to point out that data shows that market power is much more strongly correlated with high commercial prices as well. And if I had more time, I'd ask Mr. Donley, is it merely a coincidence that the highest priced hospitals operate in the least competitive markets? Can you answer in 11 seconds?
I'll just tell you, I feel that in New York City, we operate in one of the most competitive healthcare markets in the country. Recent RAND data that was analyzed showed it to be the second most competitive healthcare market in the country. We have 6 major health systems in our neighborhood.
But for those other markets where there's less competition, I mean, the trends seem fairly glaring.
Yeah, I wouldn't be familiar with the other markets. I'm certainly familiar with the New York market, which is highly, highly competitive.
Okay. Well, I wish I had more time here to dig a little deeper here, but obviously there are trends here that concern all Americans, and especially those who were told their care was going to be more affordable. Thank you. I yield back.
Mr. Thompson.
Thank you, Mr. Chairman, and thanks to our witnesses who took time to be with us today. Mr. Chairman, we're here today to discuss the affordability of health care, and I share some of your concerns, some of the issues that you raised today. But it's recent Republican policies that are making health care affordability worse today. When you cut $1 trillion from the health care system, it forces providers to cut services and in some cases shut down altogether. And as has been pointed out by a number of folks, this is going to be especially difficult in rural areas. Congressional Republicans say they only cut Medicaid, but the ripple effect will make health care accessibility more difficult for everyone. Our expert witnesses who run hospitals understand what Republican cuts will do to the delivery of health care. Mr. Hazen in his testimony said, and I quote, "Ensuring patient access to Medicaid, Medicare, and the individual insurance marketplace is one of the most direct and efficient ways to lower health care costs." And yet, congressional Republicans cut $1 trillion from Medicaid and failed to extend the premium tax credits that help millions of Americans better afford their insurance coverage. This doesn't assure patient access, it hampers it. Congressional Republicans kicked 15 million people off their insurance so they could give their billionaire donors a tax break. And it should be noted, they also added over $4 trillion to our national debt. These impacts will be devastating for hardworking Americans. Mr. Lassiter, who runs Woodland Memorial Hospital, which coincidentally is in my district, talked about the Medicaid cuts in H.R. 1's impact on his healthcare system. He said that when people become uninsured, access becomes harder to sustain. That's a quote. And I can translate that for you. Republicans are cutting Americans' health care and kicking 15 million people off of their insurance. And now hospitals will eliminate services and some will close. I can't say whether that will happen to any of the systems that the witnesses today represent, but I can promise you it'll happen. And our rural communities will be hit especially hard. Another witness here today, Dr. Waldrum, explained how rural health care will be impacted by cuts in H.R. 1. He said, quote, when the only hospital within 60 miles closes, care doesn't become cheaper, it becomes unavailable. Mr. Chairman, you've heard me say this for a year, since we've been dealing with the big bill, H.R. 1. And I hope now that the expert witnesses that you called here to testify are sounding the alarm, it'll make folks listen. Republicans' health care cuts will devastate health care access across our nation, and especially in rural areas. People won't stop getting sick, they won't stop getting injured. They'll just stop getting treatment, and some will die. Many will be sicker, and treatment will cost more. Also, the Republicans could give billionaires and corporations a big tax break, and as I said, add $4 trillion to our national debt. Someone said, I think maybe it was Mr. Waldrum, that food is medicine. Was it you? So if people don't have access, does everybody agree with that? Food is medicine? Yeah. So if we don't have good food, good eating habits, people are going to get sicker. So just a show of hands, I'll use the chairman's method here, show of hands. Who thinks that cutting $186 billion from SNAP benefits is going to make people healthier? So no one thinks that, I'm glad. Do your hospitals have separate services for Medicaid, uninsured, and privately insured patients? No, nobody? So when a hospital closes or eliminates a service, does that mean everyone in the local community loses health care access? Everybody's nodding yes. So it doesn't matter how they pay for it. If they have a truckload of money or the best insurance coverage in the world, they're going to be hurt. Thank you, Mr. Chairman. Thank you, witnesses. I yield back the balance of my time.
Mr. Kelly.
Thank you, Chairman. Thanks for holding this today. First of all, thank you for taking a day out of your lives to come here. So, Dr. Donley, I'm going to assume you say you grew up in Pittsburgh.
I did.
So my family, the McTighe family, was in the fruit and vegetable business. You may have purchased there. And the Kellys started off on the railroads, and then my dad started in 1953 in a little town called Verona with a one-car showroom and about 5 service bays, which I was able to purchase from him. And now my sons run it. We're Pittsburgh proud.
I am too.
Yeah, well, listen, listen, everything we're talking today is math. And when you hear about there's no coverage in the rural areas, just because this is what I've done all my life. In 1970, there were over 6,000 Chevrolet dealerships. Today, there's 2,800. So people say, where'd they go? Well, they're not in the country anymore because the market wasn't big enough for them to be in business. You're going through the same thing. The market's not big enough in rural areas to have people out there. You've got a facility, you've got people there, you've got people who clean the place, who do all this stuff, and I don't think people understand. It all comes down to math. Everything we're talking about is math. And when we talk about all these different cuts, we're talking about taxpayer-funded health care. I don't know how you keep up with cost. I mean, we can't. We're trying, but we can't. This year, we're going to spend $1.5 million in health care coverage for the people that work at the dealership. So we have huge deductibles, and I'm always fascinated in the same thing. We also have a body shop. Until you reach your deductible, the insurance company doesn't kick in. And so when I hear about all these things you have to write off, I get that. I get all that, because it is math. It's math. But moving forward, if you can just tell us, I mean, what is the answer? Is it more government support? Is the cost of all this taking place because there's no taxpayer putting more money into the system? If you can't exist in a small market, that's not because you don't want to be there. It's because you can't afford to be there. You can't have the people in the lobby looking for help when you don't have a doctor or a nurse to take care of them. It's just that simple. So when I hear all this stuff going back and who it is that did this or who it is that did that, and we cut costs and we took health care away from people, and millionaires and billionaires are getting all these tax breaks, I want to be a billionaire because I need a tax break. And I don't give a damn what it is. It's every single thing we do in life we pay taxes on. The locals get you, the state gets you, the feds get you, and they all start the same top dollar and take a percentage of it. Every time you go out and buy something, there's a tax on it. I'm just trying to figure out how the hell much more money do we have to have taxpayers assisting in order to keep your businesses open. And I sure as hell hope they don't start screwing around with the car dealerships, because you know what? I've got too many people I got to pay every 2 weeks, and I don't want anybody running a business that's $39 trillion in debt telling me to how run my business. Now, all of you took a day out of your life to come here today. What could we do? What could we actually do if each of you could just take a few minutes or a few seconds and say, what could we do? I'm glad we're having this, but it's math. You're not in rural areas because you can't afford to be there. The cost of operation is absolutely ruining everybody, but please, if you can start, Mr. Hazen, to go down, and I want to hear from Mr. Donley because he's a Pittsburgher, and go Steelers.
Well, thank you, Congressman. Three things, and we said this. One is coverage. Coverage is absolutely essential to rural markets. It's essential to urban markets. It's essential to Americans for affordability, for access, and for good health. That's number one. Number two is more competition. There are opportunities in some communities where certificate of need laws prevent access in capital flowing into rural markets. That's number two. And then number three, and we've talked about this, is it's really complex administratively, regulatory, and if we can find ways as a system, government, private sector, and so forth, to simplify things, it makes it easier for all people. One quick point, and I'll pass it. We have 35 rural hospitals. Since the pandemic, we've acquired 8 hospitals in this large company that I have the privilege to run. 5 were rural hospitals. So 5 of 8 we've acquired. 2 bankrupt or almost bankrupt.
Yeah.
Thank you.
Thank you, Congressman, for the question, and I'll try not to replicate what my colleague to the right said. But let me just start off with the regulatory burden is a significant issue for us. You indicated that this is just math, and so the math that we deal with oftentimes is the burden to comply with regulatory issues that at times are overlapping and are duplicative. And so I would ask this committee to consider standardizing the process for plans and providers for requests to transmit clinical information. I would ask you to think about reducing and simplifying the number of quality and efficiency measures that we have to report on to multiple agencies. I would ask you to create one claim system for Medicaid as opposed to 50 that are different, that creates for organizations like mine, and I won't speak for my colleague to the right, but with organizations who serve patients in multiple states. That's a significant regulatory burden for us, administrative burden for us, excuse me. I would ask this committee to think about stronger coverage for behavioral health. A lot of the costs that we incur in our emergency departments are because individuals do not have adequate coverage.
Yeah. Mr. Lassiter, we're out of time, but first of all, would you all submit to us in your highest priority the business model and what we need to do to improve it? The other thing, I got to tell you, we got to get on. I don't know in an outfit that puts such a burden on hardworking American taxpayers is when is enough truly enough? And if you got the government out of the way, how much easier would it be to run your businesses? All right, thank you for being here today. We really appreciate it. Keep up the good work. And I know there's a lot of sick people out there. And look, we're trying to take care of everybody we can. This is not a Republican issue or a Democrat issue. We need to get off that kick, okay? And whether it's the one beautiful bill, the one ugly bill, whatever the hell they want to call it, here's the thing. It's the bill. It's the bill. So thank you for being here.
Mr. Larson.
Thank you, excuse me. Thank you, Mr. Chairman, and thank you for this hearing, and especially the witnesses I want to thank as well. It's nice when you have CEOs that are before you that are compassionate and concerned about America, about this great country we live in. So my question to all of you, and I like what the chairman did before, I'll take a show of hands. Do you all believe that health care is a fundamental right of every American citizen? You do. All of you believe that. Well, and do you believe from the testimony that so healthcare isn't a rural or urban issue or a wealthy or poor issue, it's something that impacts every single American. And yet there are, 28 million Americans? Even though healthcare is at the lowest it's ever been in terms of people that don't have insurance. 28 million Americans don't have any insurance. I believe in the health care costs. We've had hearings where everybody's pointing fingers the other way, and there's a lot of blame to go around. But has Medicare been a program that you dislike? Raise your hands if you dislike Medicare as a program and a way to make sure that people have coverage. So, how many would be in favor of Medicare for all? Something where every single American, rural or urban, is guaranteed by the very government that they're a part of, that they have access. And then all these issues with respect to the coverage and the cost, et cetera, need to be worked out in conjunction with all the entities that are impacted by this. Mr. Donley, I had a question, too, that a constituent had, and I wanted to run it by you. The United States Department of Justice recently filed a suit alleging that the New York-Presbyterian violated antitrust laws by stifling competition between New York City providers. New York-Presbyterian has publicly commented that the suit is without merit and its policies and procedures are pro-competitive. How are your policies and procedures pro-competitive?
As you note, Congressman, we were recently named in a lawsuit brought by the Department of Justice regarding our contracting practices, and therefore I can't discuss any of the issues relating to that case. We do believe that that case is without merit, and we do believe that we comply with all federal and state laws.
Well, so while this investigation is going on, would you say that there's a cooperative nature of working towards a solution, or this is another example of people just taking sides?
We look to collaborate with all involved people to get to a solution.
Well, I thank you. Also, because of the discussion about CEOs that are here, I want to note the CEO of Hartford Hospital in my home state, Jeff Flax. This is a CEO who goes out in the winter and finds people that are homeless, sleeping under bridges, et cetera, and brings them back to the only place that they will have refuge and care. And listening to the testimony here today, it appears clearly that why policy initiatives and the so-called solutions that might appear in future bills are actually right in front of us in a bill that's been in existence but isn't accessible to all Americans. Is there anyone that disagrees that Medicare for all should be something that every single American has, so that they have the access to the very healthcare facilities conducive to make a better life, to get the kind of nutrition that's been discussed here, to have a path forward. And why should we be sitting in testimony instead of at odds, agreeing that this is what we have to do? Will all of you pledge to work towards getting all Americans covered under health care and improving Medicare for all so that it accomplishes that goal? Raise your hand if you do. So 2 of you do.
I strongly support coverage for all. I'm not a policymaker, so I don't know the specifics of that, but
I didn't ask you to make the policy. I asked you if you were for coverage for all.
I'm for coverage for all.
Thank you.
Congressman, I am for coverage for all as well, yes.
So, and Mr. Hazen?
We fundamentally believe coverage is the answer.
So with everyone believing that this is the answer and knowing from your testimony that, you know, everybody needs this coverage, and Mr. Waldrum, you were especially articulate in pointing out what the chairman's district goes through, the inequities between rural and urban areas. I could, however, point out in urban areas like the one that I live in where people go without health care as well. I yield back.
All right, thank you. Mr. Schweikert.
Thank you, Mr. Chairman. As each of you as CEOs is listening to, and hopefully you accept the premise, we've turned healthcare into financial engineering. If you actually listen to us up here, much of the discussion isn't actually about healthcare inputs, outputs, it's about the financial engineering. We have to deal with the reality, and I'm still just stunned how little I get input from the healthcare community. 6.5 years, Medicare spending goes from $1 trillion to $2 trillion. In 6 years, the trust fund is empty. So in 6 years, you're all getting a 12% cut under the current law. But how much have you heard from that of the actual demographics? Look, we have an interesting issue. Next year, the United States functionally has fewer 18-year-olds than we had 20 years ago. Double the number 65 and up. I'll be one of them next year. We have a demographic. I've had only one member of the panel sort of talk about, and we're going to have a little discussion about your patient mix, severity mix, and some of the inputs with that. Look, it's one of my intense frustrations is we as policymakers often are desperate to find someone to blame because we want to feed simplicity to our voters. What happens when the reality of is a complex problem requires a complex solution? Are we capable of doing complexity? Mr. Lassiter, if you were to actually say, what's the difference in the patient presentations you have today compared to 20 years ago in health, obesity, complexity, multi-chronic issues? How different does your world look in your patient mix today than 20 years ago?
So I would say I will speak in generality, sir, only because I wasn't at my current organization 20 years ago, and so I can't speak to what that population...
Look, it's a thought experiment.
No, I understand.
I'm heading towards making a point here.
Yes, absolutely. So I think what you would find, and I believe this would be shared across the panel, you would find that patients that present to hospitals today are sicker, they have more comorbidities than they did 20 years ago. You would find, as you see in general research, that the level of obesity in our populations would be higher today than it was 20 years ago. Those are the things that you would see, whether patients are presenting at a primary care physician's office or presenting at a hospital emergency department. Okay. That's what you would see.
Right, to that point, does the panel substantially agree with this? I mean, you can just
grunt at me yes or argue with me.
Yes, we are seeing much sicker patients.
So what would happen if one of the most powerful things we could do is actually having to do with Americans' health statistics? We have a data set that my Joint Economic Committee published about 2-3 years ago. Controversial. I thought we were going to get the crap kicked out of us because we told the truth about the math. We showed that almost 9.1 trillion over 10 years of healthcare costs was obesity, that 47% of U.S. healthcare costs were related to obesity, and yet somehow we think it's moral to hand someone an EBT card to go buy onion rings. We live in a time of technology miracles. Maybe part of our fixation is coming up with a much more holistic view of how you run your organizations. I'm enraged how much of a healthcare hospital bill is the air conditioning, is the parking lot, is the infrastructure, but that's what you're required to do in today's model. Maybe dealing with the reality of I have a population that's getting older very fast. I got, 76 million of my brothers and sisters who are baby boomers. Geriatric health care and the population, when 31% of Medicare spend is just diabetes. We actually know how to attack this and approach this, whether it be a combination of some of the new drugs that are on the market to incentives to actually be healthier. Maybe my solution, maybe our solution as a society is deal with the reality of our demographics, try to help our brothers and sisters be healthier, and then we're going to have a world of how do I get market technology, whether it be wearables, other things, to basically make you all compete like crazy. Because honestly, in 6 years, Medicare spending doubles and the trust fund is gone. And we're not prepared to deal with the scale that's coming at us. With that, I yield back.
Ms. Sanchez.
Thank you. I want to welcome all our witnesses and thank you for your testimony today. Mr. Lassiter, I agree that we should pass the Medicare Advantage Prompt Pay Act, and I assure you that Mr. Arrington and I are working to secure a legislative hearing on that piece of legislation. But I want to talk to you about something a little bit different today because I believe you're the only witness on the, in our hearing today that has a presence in my district. I want to ask you about an issue that has impacted my constituents directly and one that has been raised in many of the town halls that I've conducted. Last summer, ICE began terrorizing the communities of Los Angeles. So I want to ask a very simple question. Do you believe that immigration enforcement should be conducted in a healthcare setting?
Congresswoman, thank you for the question. What I would say to you is this. I believe strongly that in a healthcare setting, we should deliver healthcare, and we should do that in an unencumbered way. My organization, as I would presume all that are here, are committed to trying to deliver the best possible care to the patients who present to us. And so what I would simply suggest to you is that we should be able to deliver that care in an unfettered way as seamlessly as possible to meet patients' needs.
Thank you. Do you believe that ICE agents or any federal immigration officer should be present in an emergency department when a patient is seeking care there?
Well, CommonSpirit works very closely with law enforcement to ensure that there is appropriate respect of all local, state, or federal officials. I won't opine explicitly on the issue around ICE, except to say again that I would not be in favor of anything that disrupts the ability of caregivers in an emergency department to deliver high-quality care that meets the patient's needs.
Okay, I appreciate your answer. I'm asking about this because in July of last year, U.S. Immigration and Customs Enforcement agents occupied Dignity's Health Glendale Memorial Hospital for 15 days. And at times they were waiting for one patient in the emergency room, behind the reception desk, and in the patient's own room where they were getting care. Do you know if Glendale Memorial Hospital has a written policy and standard operating procedure for interacting with immigration agents? Do you have that policy?
Well, we certainly have a policy for interacting with all law enforcement, And again, we're respectful of boundaries for local, state, and federal law enforcement.
So you do have a policy?
That's correct.
Thank you. I appreciate brief answers because we have limited time. In September, California passed Senate Bill 81, which would require California healthcare facilities to create and designate non-public areas to protect patient privacy. It further directs healthcare providers to establish clear procedures for responding to immigration enforcement in healthcare spaces. This was a direct response to President Trump's executive order, which, for the first time in a decade, allowed federal immigration agents to conduct enforcement inside healthcare facilities. Mr. Lassiter, I understand you've overseen the entire health system since 2022. Can you speak briefly as to how President Trump's directive impacts routine patient care, specifically at Glendale Memorial?
Congresswoman, I don't know that I could speak specifically to what happens on a day-to-day basis at that facility because I'm not physically there regularly. But what I would say to you is when we have individuals in the healthcare space that are not delivering healthcare, it can be disruptive. And we work hard to make sure that we work collaboratively with law enforcement.
Thank you. I mean, prior to this, there was a sensitive locations memo which did not allow ICE enforcement within a healthcare setting. In Southern California alone, nearly 30% of patients have reported missing or canceling appointments due to immigration concerns. I understand, I just want you all to know that the healthcare industry is in very uncertain times. The Republican tax bill, which gave a tax cut to billionaires, just cut $1 trillion from healthcare programs last summer. I know that tariffs, illegal tariffs, are driving up the cost of medical supplies, general hospital and health system costs, and procurement as well. Immigration enforcement is decimating our caregiving and long-term healthcare workforce. A cruel immigration regime is deterring people from getting to their doctor's appointments. So I understand you're facing a lot of headwinds, but I think it's incumbent upon a local hospital, especially one that was founded on caring for our most vulnerable community members, to provide a safe space for parents and their families. And I wanted to talk about this particular issue today because this week the House is voting to progress another $70 billion in funding for Trump's ICE and CBP enforcement. And that kind of enforcement isn't stopping anytime soon. So I fear that if you do not have policies that put the patient's health above all else, this could also be a real disaster for our healthcare industry. And with that, I will yield back.
Mr. LaHood.
Thank you, Mr. Chairman, for having this important hearing today. I want to thank our witnesses for being here today and your valuable testimony. Obviously, the title of today's hearing is the impact of rising healthcare costs on patients and families. And as we've heard this morning already, this is a topic that is top of mind for all of us from a public policy standpoint, from a political standpoint. We have to do something on healthcare. And so ideas, suggestions, proposals, comments are important. We also are building upon what we earlier this year had before the committee, which was the leaders of the major healthcare companies on how to address the challenges of limited access, rising premiums, and growing out-of-pocket costs for patients. Today's hearing is a continuation of that and that conversation. And I believe that rising costs should be addressed comprehensively by the entire healthcare system. Insurers, hospitals, drug manufacturers, and PBMs all share responsibility for improving affordability and access. And I would argue we have an obligation and responsibility to move forward with that. I regularly hear in my own district from families and employers and providers across Illinois who are concerned about hospital consolidation, higher facility fees, and billing practices that are increasingly difficult for patients to navigate or to understand. Those pressures can increase costs without necessarily improving quality or access. In rural communities, and I have a very rural district, these challenges are even more serious. When a hospital closes a service, loses staff, or reduces access, patients may have to drive hours for care, which is inconvenient and very, very difficult. I and many of my colleagues here strongly support market competition. And I also support vital safety net programs like Medicare and Medicaid and the 340B program. With Illinois having a significant participation in 340B, we must ensure that this lifeline reaches the vulnerable patients in rural hospitals that the program was intended to serve. That's why when market power grows significantly or when public programs are used in ways that do not clearly benefit patients, lawmakers have a responsibility to intervene and assess what's broken within our system. And that's what part of what today is about. So I look forward to discussing on how we can lower costs, strengthen rural healthcare access, and ensure patients are kept at the center of our system. With that, I want to ask a question regarding 340B, which of course is the drug pricing program designed to lower outpatient drug costs for providers. Dr. Donley and Dr. Waldrum, can you please share on how you utilize 340B to provide better care for patients and what oversight or reporting requirements must be followed to receive the 340B, ensuring that the resources are directed back to patients?
Sure. Thank you for your question, and I agree completely with you that there's many stakeholders, and all of us, including hospitals, have to play a role in finding a solution. In regards to 340B, we do believe that we use the resources that we obtain from 340B to take care of vulnerable patients as the program was designed. We have a $2.4 billion community benefit. That's over 20% of our operating expenditures. For nonprofit hospitals, the average is around 9 to 14% of operating expenditures for community benefit. Specifically, we provide $1 billion shortfall of care to patients who are insured by Medicaid.
Dr. Waldrum.
Congressman LaHood, I appreciate the question and the importance of affordability. I think that it's important. My whole career has been in safety net organizations, as I've mentioned, and using these programs to support our communities and make sure that they have access to care and the significant burden that we all face with uncovered lives. And so this is a really important program for maintaining access in rural populations. And I think it's important to point out that this is not a federal, the feds don't pay for it. This is a program that's put in place, and I get that pharma doesn't like it. However, this is really important for us to maintain the programs that we need to maintain to have the access, and it's not about convenience, it's actually about lives. We need to not increase the administrative burden. As we've mentioned, 20% of our healthcare dollar is spent on administrative burden. Managing the complexity of the insurance markets, Medicaid Advantage is overwhelming our staff and our reporting, and adding to the administrative burden of this important program will only increase the costs and diminish the benefits that it helps for safety net organizations.
I'm out of time. I yield back, Mr. Chairman.
Thank you. I now recognize Ms. Delbini from Washington for 5 minutes.
Thank you, Mr. Chairman. Thank you all for joining us today. Prior authorization is a tool that is used by health plans to manage costs by requiring healthcare providers to obtain pre-approval for medical services. Theoretically, people may think this sounds reasonable, but in reality, it often denies beneficiaries access to services even when they meet coverage rules. In fact, one KFF analysis found that in 2024, more than 80% of the appealed prior authorization denials were overturned. And ultimately, these unnecessary denials delayed patient care, added administrative burdens on clinicians, and hurt health outcomes for patients. Mr. Lassiter, you represent CommonSpirit, the parent organization of Virginia Mason Franciscan Health in my state of Washington, many clinics also in my district. I wondered if you could comment on how prior authorization has affected patients that you serve, obviously in Washington, but across the country.
Thank you very much, Congresswoman, for the comment, for the question. I would just simply say this. Prioritization, as you indicate, is a tool. Health systems are experiencing that tool being misapplied at times to procedures that should be quickly authorized that are not, or denied authorization for procedures that clearly are within the coverage plan that patients have. We experience that frustration. We hear it. Our frontline teams hear it from patients who experience delays in being able to schedule procedures. And that comment is sort of across the system, not specifically to Seattle or state of Washington, but broadly. And again, we believe that some of the administrative oversight and the work and rework that's required there, we estimate that for us, it's about $1 billion worth of additional time and effort spent chasing down authorizations, pre-authorizations, denials, et cetera.
And not only delaying denying care for patients, but you talked about the burden on clinicians and others, the paperwork. When folks are spending more and more time doing paperwork, they're not able to actually see patients and do the work they're there for. You know, I absolutely believe we should look at innovative solutions to reduce hurdles that stand between Americans and the health services they need. So I was definitely alarmed to see this administration do the opposite and leverage AI tools to deny people care in traditional Medicare. 2 weeks ago, we had Secretary Kennedy here. He came in to testify in front of this committee. I asked him about the implementation of the new wasteful and inappropriate service reduction model, the WISER model, which is actually is happening in Washington State. It's launched in 6 states, including the state of Washington, and allows for-profit companies to use kind of black box algorithms to deny Medicare claims. And even worse, it financially rewards these companies with a share of the costs that they claim to have saved by rejecting physician-prescribed care. So, Mr. Lassiter, if we speak specifically about the WISER model, which is in Washington, what is your relationship and communication like with these companies that are actually doing the prior authorization, the for-profit companies that are doing prior authorization in the WISER model in states like Washington?
Congresswoman, thank you for the question. It's a little early for us to have a bottom line point of view about the WISER model. We have concerns about entities that have incentives to disallow appropriate claims. We liken this to some extent to the days when we had those Medicare RAC audits and you had the audit firms who had a financial incentive to deny claims. We see it somewhat similar to that. Again, it is early. As you mentioned, it's in 6 states. Washington's one of those. Our team is closely monitoring the effects, positive, negative, or neutral, of the WISER model. But I have some concerns about the misalignment of incentives between the firms that are doing it and what they are, the basis of their payment.
Thank you. And we are hearing directly from patients across the state who are being impacted from providers who know their patients are having their care delayed. It's more expensive. So this idea that somehow this model was supposed to save money is actually make it harder and harder for patients. Thank you so much. I yield back, Mr. Chairman.
Well, thank you, and I now recognize myself for 5 minutes. I appreciate all the witnesses for being here today. You know, I want to start off a little bit first with just talking about some of the positive aspects that impacts on healthcare systems can have when they actively invest in the communities. In my own district, HCA's Wesley Medical Center delivers more babies than any hospital in Kansas. And to address the severe workforce shortages, HCA recently opened a Galen nursing campus in Wichita, fully funded by HCA and tuition without public dollars. And they now have over 200 patients and are proactively partnering with 9 other local nursing schools to ensure no existing clinical rotations were disrupted. This is a true addition to our state's workforce and not a replacement. Wesley's hired over half of those graduates, and the rest are serving other communities across Kansas. That's the type of local investment we like to see, and appreciate that effort. We do want to look, though, at, as we talk about the broader national landscape, as been brought up earlier, the rapid commercialization of our medical care is concerning. We're watching as the large systems swallow up independent practices, creating local monopolies that drive prices for patients without necessarily improving the quality of care. a massive driver for this consolidation, as we've seen, and creates a heavy burden a financial burden for our patients, is the broken system around site neutrality. I mean, right now, Medicare and commercial payers generally pay significant more for care provided at an outpatient facility that's owned by a hospital compared to the exact same facility if it were owned by an independent doctor. Because of this, when large hospital systems buy up independent practices, they routinely add huge facility fees onto the regular outpatient services. In fact, patients can end up paying up to 4 times as much for routine care just because a hospital acquired the clinic, even though they see the exact same doctor. And this payment loophole incentivizes health systems to continually purchase independent practices simply to bill at a higher rate. I want to talk a little bit about that. Obviously recognize that in a hospital setting, there are some additional costs. I mean, having an ER, having maybe an on-site pharmacy or other facilities does add some of those costs, but it doesn't necessarily affect the actual services provided at an outpatient facility that may have been just recently acquired. One of the reasons why I want to talk about this is just the impact on seniors who, living on fixed income, sometimes pay 20% of their out-of-pocket for outpatient services. For example, a senior may pay $50 copay for a checkup at a hospital-owned clinic instead of $20 copay for an independent doctor. How do you look through that with your systems? I mean, and this is kind of a question for anybody: is there $30 value added to that patient because the facility is bought? Dr. Waldrum?
Yes, Congressman, I appreciate the question, and I think that the assumption that we are consolidating out of profit motive is wrong in rural America. In our market, I can only speak to what we face, and I've never bought or sold a practice because any of the doctors or hospitals or communities wanted to actually make that happen. Our system grew because of all 8 rural hospitals were failing and were about to be closed when those communities approached us because they had years of deficits in their community and they were losing doctors. And in Martin County, a county about 45 miles north of Greenville, North Carolina, 3 years ago, that rural hospital closed. It was a for-profit organization, closed because they couldn't make it in that community. It left that community as one of the largest healthcare deserts in the country, and for us to sustain care and pay the overhead and to provide access in those communities, the provider-based reimbursement helps us meet that obligation. So we're working with the state, we'd like to work with feds, and we're working with that community to try to find a solution, and this is one of the programs that helps us meet this.
And I think that's a good use of consolidation practices. I mean, I have a lot of counties in my district where 4,000, 5,000 population in the entire county, and that's not enough to support that ongoing either competition or let alone support a standalone hospital. And I'm worried more about the standalone clinics that get bought that aren't necessarily a hospital and the impact there. And so anyway, I've got so many other questions, a lot of things that we've talked about, rural classification and the impact there. And we really got to figure out a different way of doing this. And so I've run out of time, but I want to make sure that we focus on how do we lower the healthcare costs for everybody across the country. Now, pursuant to committee practice, we will go to 2-to-1 questioning. And now I'll call on Mr. Arrington for 5 minutes.
Thank you, Mr. Chairman, witnesses. I want to follow on the line of questions that Chairman Estes articulated. First, I think it's probably been well established. I think everybody understands that the current system is broken, fundamentally broken. It is not delivering in a country as wealthy and as capable technologically, as rich in resources, in personnel, in brick and mortar. We should not be the least efficient system in the developed world. a third of the budget, and a third of what's driving us further into the tens of trillions in debt hole with a looming debt crisis is healthcare. It's 20% of the economy. You look at Medicare with 10,000 baby boomers retiring every day. We're going to go from $1 trillion to $2 trillion in less than 10 years. 1 in every 4 Americans in 2022 were on Medicaid. In 22, Medicaid was almost $600 billion. That was a 45% increase from 2019. And these are just 2 programs, the largest healthcare programs in the federal government. We cannot sustain this. And it's going to end really badly if we don't do something about it. And I haven't even gotten to the consumer or the patient price unsustainability. But in 2015, Congress passed the Bipartisan Budget Act, established site-neutral payments under Medicare for services received at off-campus HOPDs, basically hospitals, unless the location was already billing as a hospital department prior to the date of enactment. Mr. Chairman, this grandfathering clause and other exemptions in the law have resulted in a perversity that is driving cost up for patients, premiums for Medicare beneficiaries, and taxpayers that are paying the freight of the system. I'm talking about site neutral, where in Plainview, Texas, it's real simple. We're paying hospitals a whole lot more for the same outpatient procedures that physicians conduct with the same outcomes, often with the same mid-level support. And you've got, for example, biopsies today on average cost about $150 at a physician's office. It's $800 at a hospital setting. And there's a whole list of things, epidural injection, $250 at a physician's office, $740 because of that HOPD payment. Now, there are some things hospitals can do that outpatient physician groups can't. We want you to be motivated to do that and do that well. There's a cost structure associated with it. We want you to be adequately funded. But if we just did what President Obama suggested in his budget, what Joe Biden included in his budget, and yes, Donald Trump included in his budget in his first administration, we could save $160 billion that would go to reducing the deferred tax on our children or the national debt. We could, among other things, save $94 billion to beneficiaries, $672 billion for greater health care, for the greater healthcare system, and on and on. It's a simple, straightforward thing, Mr. Chairman. And to my Democrat colleagues, this was led, I think, during the Obama years, and we've carried it over into all of our budgets. But just like we say we want to get rid of waste and fraud, and we put it in the budgets as a saver so we can show that we're getting close to balance, we don't do jack squat about it. Now, we did, and then we got vilified by our Democrat friends for supposedly cutting benefits, and all we were doing is cleaning up the system so we could sustain these programs and so that we could also steward tax dollars. But yet, here we have another opportunity, Tom, another opportunity to do something that both sides have said is important, is common sense, straightforward, save the system money. Why wouldn't that? Raise your hand if you think that's a straightforward, common sense idea that we ought to do to help save the system from collapse, if not the entire country from a fiscal or debt-related crisis that could be potentially irreparable. Do you think it's a good idea to have site neutral, or are y'all against it? So no hands, no takers for that. But look, I'll give you, Mr. Hazen, give me your comments. I know my time's expired, so you'll be the last word on this. But I didn't get any takers on site neutral.
I think there are certain aspects of your discussion here that have merit. I think there's also merit to the hospitals receiving a premium in certain circumstances. So we would be more than willing to work with you on it.
I think that's fair, and I want to be sensitive to those nuances so we don't hurt you while helping the system. So let's work together and get it done. I yield back.
Thank you. I now recognize Ms. Sewell of Alabama for 5 minutes.
Thank you, Mr. Chairman. I want to thank all of our witnesses for being here today. My Alabama district is both urban, Birmingham, as well as rural, the Black Belt of Alabama, which is where I grew up in. And all what they have in common is that they are areas where underserved people live. And so there are lots of needs in my particular district. But if anyone knows what's possible from that district with resources, opportunities, it's me and my staff, and we work hard every day to try to provide those resources and opportunities to the people of the 7th Congressional District. Alabama has a bare bone minimum Medicaid program. We have the lowest Medicare wage index, meaning that Medicare reimburses our hospitals at 65% of costs compared to more wealthier cities and states at 150% of cost. We have fewer folks on private insurance, so our hospitals are heavily reliant on Medicaid and Medicare reimbursements. And most recently, I held a roundtable with my rural hospital CEOs, and over 7 of them attended, as well as several executive directors and CEOs of community health centers. They are exhausted. They are exhausted because they feel like they're getting hit by all sides and that there's no end in sight. They aren't hopeful about the Rural Health Transformation Fund because they don't think that it will trickle down to their hospitals. When compared to the pending Medicaid cuts as well, they think that they're in a no-win situation. Mr. Waldrum, Dr. Waldrum, I want to thank you for being here today and for your work at UAB, the former CEO of University of Alabama Hospital in Birmingham. I also want to thank you for your leadership in the AAMC. I'm proud of your partnership on my bill to expand medical residency slots. I think all of us wanted to make sure that we have as many residents as possible, especially for rural parts of our districts. You're familiar with the state of Alabama's Medicare, and I wanted to see if you would give us an assessment on how you think that the rural and safety net hospitals will fare under the Medicaid cuts, and your thoughts about the Rural Hospital Transformation Fund. Dr. Waldrum.
It's good to see you. Thank you. And as mentioned, I've spent 20 years of my career in Alabama running one of the country's largest safety net organizations in downtown Birmingham, and have visited every rural hospital in the state of Alabama, just as I have in our market of Eastern North Carolina. And they're very similar demographically and from a rural context. So I very much appreciate and understand the issues that your constituents are facing. The fact is that when we look at the H.R. 1 and what it will do for funding in rural environments, we see a fairly large reduction in reimbursement. The year after next, we will realize a $30 million decrease, which starts to compound year over year, and over the next 10 years, conservatively, is $1 billion in cut to our rural delivery system. And then we appreciate the fact that the Rural Health Transformation Fund that underscores that there's really a difference in rural and urban environments.
And I think we all know that.
Yes.
And I think that the challenge, of course, in Alabama is that we didn't expand Medicaid, and we also have the lowest wage, Medicare wage index. And I know that our whole delegation has been fighting to increase that. But to increase Alabama and other southern states means you have to decrease New York and other West and East Coast, and so it's a win-loss proposition for so many. Your thoughts about what we can do with the Transformation Fund, as well as your thoughts about, you've said that the cuts will be devastating. How devastating will they be for rural and underserved communities?
Well, we are starting to plan, and it will, if we don't get relief, we'll be closing access and services. So that's just a mathematical reality. And so I think that will play out. The amount in the Rural Health Transformation Program will not offset and is not nearly Every state's different, so I don't know exactly how the Alabama
Well,
program.
Alabama's getting $200 million for that first year, but they've also said that that transformation fund, I know every state is different and can develop their own, but our transformation fund will not be for operational costs or deferred maintenance, both of which are critically important to those facilities staying open. Again, I want to thank all of our witnesses for being here today, and just wanted to say that we have a lot of work to do, Mr. Chairman, when it comes to really undergirthing our rural hospitals, and I look forward to rolling up my sleeves and working in a bipartisan manner to make that happen. Thank you.
Thank you. I now recognize Mr. Smucker from Pennsylvania for 5 minutes.
Thank you, Mr. Chairman. Thank you to each of you for being here. It's an important conversation. We all want to ensure that everyone has access to the health care that they deserve and at a price that they can afford, and to the insurance, access to insurance they can afford as well. And there's a lot about the marketplace in health care that is not an efficient marketplace due to a lot of regulations and rules that have been put in place by many folks here and those that were here before us. But I do want to, before I get, want to get to a line of questioning, but I'd like to respond to some of the things that Democrats have been saying and also their witness, Mr. Woodhouse. We heard Mr. Smith debunk one of the claims about a facility that closed in his district. I also want to say that the data that he cites, about 800 hospitals are at risk of closure. That data was available, and the data he's using was from 2019, well before the bill that Republicans passed was even being considered or passed into law. He also quoted, and Democrats have quoted, 15 million people who will lose their health care. I've seen you all nod along. Do you know who's going to be losing their health care? Does any of you know? The 15 million people that will be losing their health care? Anyone? CBO actually addressed this, and I'll tell you who it will be. So 6 million are able-bodied adults without dependents who are working age, who choose not to meet modest Medicaid work requirements that have been put in place with this bill, or they choose not to fill out common sense Obamacare verification forms. We want to ensure that taxpayer dollars are being spent on people who truly need it. So that's 6 million of them. 1.4 million are illegal immigrants. Some states allow illegal immigrants to access benefits. That's 1.4 million. 3 million are people already ineligible for Medicaid, and they simply haven't been removed from the program yet, or have access to other subsidized coverage besides Medicaid. And 5 million are potentially due to the expiration of the expanded Obamacare tax credits that Mr. Woodhouse talked about that have increased costs. Those were put in place by Democrats, set to expire, and we're seeing the cost increase because of that. That is what CBO has said about the 15 million people who will no longer be eligible. The other thing about Obamacare, which Mr. Woodhouse talked about, the cost of Obamacare premiums has doubled in the last 10 years, has gone up well above business insurance plans, and in fact is almost double, 180% of a business insurance plan that would be comparable. So there's a lot of work to be done. There's a lot of blame on Republicans, but those are just some of the facts. I want to talk a little bit. I noticed one of you is a for-profit, 3 are not-profit. And of course, we in the tax code designate nonprofit status for companies that are providing some public benefit. And of course, the government, the federal government, gives up tax revenue as well as local communities. So for instance, in my community, Lancaster City, houses a lot of Penn Medicine's facilities and forego or do not receive tax benefits as a result of that. When I look at your systems, I don't know that I see a lot of difference between a for-profit and a nonprofit. Mr. Hazen, you're the for-profit. Do you think there's much difference in the way hospitals that are designated for-profit operate differently than a nonprofit?
Thank you, Congressman. I've had this question posed to me many times, and the short answer is no.
Okay, thank you. And I'm sorry, I'm running out of time. I'd like to go to Mr. Lassiter. Your compensation seems to be maybe on par with a for-profit. Your compensation was $21 million last year. Is that correct?
That's not correct.
Okay, what was it?
It was 14.
14 million? Okay. Is that in par with what a for-profit would be receiving, or is it more?
Well, I can't answer that explicitly. What I can say to you is
Do you think that your system is using some of what would have been paid in taxes to compensate you?
No.
Do you think that public benefit includes $360 million invested by your organization in Central America and Europe?
We have no operations in Central America.
You invest in publicly traded securities?
Okay.
Is that right? $718 million invested in publicly traded securities, $134 million gain by those securities?
Yes.
163,000 spent on board meetings in Europe, Canada, and Mexico?
That's not true.
Okay.
We do not hold board meetings.
Can you explain to me why you should be granted nonprofit status? Sorry, Mr. Chairman.
So on an annual basis, CommonSpirit delivers about $5.2 billion a year in community benefit. That is approximately 12 times the value of our taxes foregone. When you think about the community benefit that my organization...
And I'm really sorry I'm out of time. I would love to ask Mr. Hazen how much community benefit they provide just for comparison, because they being a for-profit, but I know I'm well out of time. Thank you, Mr. Chairman.
Thank you very much. Gentleman's time has expired. I now recognize Dr. Murphy for 5 minutes.
Thank you, Mr. Chairman. I will say I've had an illustrious and very, very rewarding career practicing urology in Eastern North Carolina. I also served as Chief of Staff of the ECU Medical Center, a 1,000-bed hospital, now a 1,000-bed hospital. It serves a 29-county referral area, and as Dr. Waldrum pointed out, one of the poorest referral areas in the country. I know the vocabulary. I know how to speak the language. I know that healthcare is very complex. Yet we are in a situation now that is untenable and must change. It must change. I will just, before I get started, I want to give a shout out to ECU Health. I've worked in that system for 35 years. It is the paragon of what mission health is supposed to be about, serving a poor, less accessible area, taking care of those who are marginalized, taking care of those who have no access to healthcare, and as Dr. Waldrum pointed out, accessing hospitals which would otherwise have failed. It has been my honor to work in that healthcare system, and I think they do a fabulous job. Sadly enough, the beast of our existence, United Healthcare, they're now in negotiations with this. United, which earns billions and billions of dollars of profit every year, is now trying to skim pennies off a poor Eastern North Carolina system. I wish you well in your negotiations. I hope someday the FTC breaks up United Healthcare and turns them into dust, as I asked that they be done before. It is ridiculous that for-profit insurance companies, and I think all of us can agree on this, are preying on the American patient, making partly healthcare unaffordable. Just as a recognition, I understand hospital costs have gone up. Regulations, government regulations go up. Labor costs have gone up. We saw that with traveling nurses during the pandemic. Medications have gone up, which in some ways is a good thing. We're keeping patients alive. Electronic medical records costs have gone up. Liability costs gone up. C-suite compensations. They're ridiculous. They're ridiculous. And it's hard to make a justification for some of those sometimes when patients cannot afford health care. Democrats love to feed the beast of increasing health care costs. You talked about the ACA extended subsidies. All those did were insurance company benefits and profits during that time. That's what they were doing. And as my friend Mr. Smucker pointed out, what a great correction of the record about who is really getting their, quote, health care removed. We need to rethink the urban-rural classification. We have institutions that are taking advantage of this. That's just wrong. It's just wrong. We need to rethink that completely. If you look at why rural healthcare is suffering so much, it is because manufacturing has gone in in all areas, especially in Eastern North Carolina. Government subsidies are only a panacea. They don't get to the problem. I'm glad we have a president that's trying to bring manufacturing back to this. So I racked my brain because I still see patients and they come in and talk about the cost of health care. How do we do this? There's culpability everywhere, from hospitals to insurance companies to pharmaceutical companies. There's even plenty of culpability for physician associations for, instead of teaching how to order one more test, how do we do things more slightly? We have to fix this problem. We have to fix this problem. Medicare for All is a ridiculous initiative. You want less government. You want less government in the situation because that's some of the worst problems that we have today. So it brings us back to why is healthcare so unaffordable these days? In many different institutions, their for-profit status, really, I think we have to question it today. It was fine 10 and 15, maybe 25 years ago, but it's gotten to be out of control where now institutions are more aligned and care more about their dividends and their shareholders than the patients themselves. I have to stare directly at patients every day when I see patients and explain this system to them. Mr. Hazen, your institution, I had the honor of going out to Mission in Asheville. Tremendous job they did after Hurricane Helene. Tremendous initiative, putting in a drill, 48 hours to get water. I was really blown away and thought they did a wonderful job right after the hurricane. But I need you to help me understand something. In this case of unaffordability, how can you justify a for-profit institution when you guys made $6-7 billion in profit, returned to shareholders, none of whom have anything to do with health care, when people cannot afford their health care premiums? Help me understand why we should allow for-profit systems to exist.
Congressman, thank you for acknowledging our team at Mission. That was a Herculean effort. I went through Katrina as well, so I'm really proud of our folks there. I will tell you, I think our model is the model. It's the solution in many instances. In addition to the $5 billion roughly of uncompensated care costs.
Look, believe me, I get the whole uncompensated care thing. I get it. I understand this, but how can we justify in today's market, when people cannot afford health care, that there are systems that are survived just for profit? Now, I'll extrapolate this to our wonderful United, to our health insurance companies. United is the third largest corporation in the country. How does this extrapolate to patients who cannot afford health care today?
Well, our focus is on our patients. We have 33,000 patients in a bed right now, and we're 100% focused on them.
The bottom line is we can't justify it in today's market. We cannot justify that billions of dollars are taken out of patients' pockets, not being able to allow them to access health care, and that it goes for profit on stock markets. We just can't do that anymore. Now, I don't want to sound like a communist. I'm not. I'm a capitalist at heart. I absolutely believe in this. But if we now have institutions that put profits above patients, and I'll beat more on the insurance industry than anything, we have to rethink this model. Thank you, Mr. Chairman. I'll yield back.
Thank you, gentlemen's time's expired. Chair would like to remind members and witnesses to please limit their comments to 5 minutes allotted. And now recognize Ms. Chu from California for 5 minutes.
Mr. Woodhouse, undermining vaccines drives costs through the entire healthcare system, including hospitals. Preventable infections lead to more emergency room visits, more inpatient hospitalizations, more ICU admissions, and more uncompensated care. The Trump administration has spent months undermining trust in vaccines. They've fired independent vaccine experts, empowered vaccine skeptics, and spread serious doubt about vaccines that we know are safe, effective, and life-saving. One of the clearest examples is hepatitis B. For more than 30 years, the recommendation was simple. Every newborn should receive the hepatitis B vaccine within 24 hours of birth. That universal birth dose helped drive a nearly 99% decline in hepatitis B infections among children. But after Secretary Kennedy totally reshaped the CDC's vaccine advisory panel, the recommendation was overturned. So it's no surprise that just yesterday, a new study in JAMA Pediatrics came out warning that even a short delay in the hepatitis B vaccine could mean hundreds of additional infections, more cases of liver cancer, more preventable deaths, and tens of millions of dollars in added healthcare costs. That does not sound like making America healthy again. And we are seeing the same dangerous erosion of trust around vaccines for measles, the flu, and COVID. So, Mr. Woodhouse, can you explain how these attacks on vaccines are not only dangerous for public health, but are driving up costs for families, hospitals, and taxpayers? And what should Congress be doing right now to undo the damage that has been that has been occurring recently and restore trust in vaccines and stop paying so that we can stop paying for more preventable crises?
Well, Congresswoman, thank you for that question. I would say the first thing that Congress should do, or maybe President Trump should do, is show RFK Jr. the door. I mean, this is someone who came into this administration having spent a dozen years, or much of his adult life, sowing conspiracy theories about vaccines. It was a grift. I mean, he had a nonprofit that he was making lots of money off of that was selling disinformation about vaccines, selling disinformation about the measles vaccine causing, autism. And he has sown more disinformation and discord in this regard since he's been Secretary of Health and Human Services. We've called for his resignation. I don't know a Democrat on Capitol Hill that hadn't called for his resignation. Public health is a disaster because of RFK Jr. We have the largest measles outbreak in this country in 20 years. We are very likely this year to lose our measles elimination status. He has undermined confidence in the COVID vaccine, in the measles vaccine, and of course, more people. Let's take South Carolina. I mean, in the area of Greenville, South Carolina, where in that area where measles has exploded, and RFK Jr. hadn't stepped foot in South Carolina to address the measles epidemic there. He hadn't set foot in South Carolina and said, yes, you should get the vaccine. Yes, there is no link between measles vaccine and autism. So obviously that's going to have increased healthcare costs for people that have to be cared for.
Well, let me ask, just turning to another topic that is, to me, very essential, which is about private equity and how that's affecting hospitals. When hospitals are financially stable, they're able to make decisions based on patient care. But Republicans' big ugly bill is pushing hundreds of hospitals to their breaking point. Hospitals are losing Medicaid revenue, facing more uninsured patients, and being forced to cut services just to survive. And when they become distressed, then private equity comes in. And oftentimes the priority is not patient care, but investor return. And private equity is often the kiss of death for hospitals. In fact, it's hard to think of a business model less compatible with healthcare than private equity. So, Mr. Woodhouse, does Republicans' big ugly bill make it more likely that struggling hospitals will be pushed into these kinds of arrangements?
Well, let me say a couple things here. One, we have 889 pins on our map of hospitals that are struggling. I think there's no doubt that creates a sense of desperation, and that's the very type of thing that can happen. I'll say another thing. None of the data on our map is from 2019. None of the data on our map is what Congressman Smucker said it was from. The very first pin we put on our map was the day this bill passed, and it was sent to the president. It hadn't been signed yet. A hospital in, forgive me, I believe it was Oklahoma or Nebraska, but they looked at their financial situation. They looked at what they were likely to get cut from Medicaid in future years, and they closed. Before the bill was signed by the president, they announced their closure. That was the first pin on our map. That was not in 2019.
Thank you for clarifying that, and I yield back.
Thank you. I now recognize Mr. Fitzpatrick from Pennsylvania for 5 minutes.
Thank you, Mr. Chairman. Year after year, my constituents in Bucks and Montgomery counties are seeing rising health care costs, forcing many to make impossible decisions when it comes to necessary care. The consolidation of healthcare systems over the past several decades, among other factors, raises serious questions regarding the rising costs of care. I want to focus my questions on workforce challenges that have had a direct impact on rising costs, including a specific example from the SEIU in my home district. Mr. Donley, many labor unions provide health insurance for their members and their families, including in Pennsylvania's 1st Congressional District. Unions, like thousands of employers across the country, use price transparency data from the administration's Price Transparency Initiative to garner information on their premiums. They found New York-Presbyterian charges much higher than Medicare for their care, to be precise, 358% more. After this union dropped New York-Presbyterian from their network, they reportedly saved substantial resources, allowing for more financial flexibility for their members. Mr. Donley, I assume, like most private health plans, you have to build in some cost shifting in order to help offset losses from the Medicare and Medicaid patients that you serve. So my question, Dr. Donley, does this situation that I mentioned cause any changes or considerations to the prices that are charged?
As you note, pricing is very complex. There's many different variables. I will tell you, New York-Presbyterian, as we look at pricing, what we look for our pricing to be based off is the quality care that we provide. We're very proud to be a 5-star CMS hospital, recognized for our quality. Only 10% of hospitals in America are recognized as 5-star. The other thing we look at when we price is the complexity of the illness of the patients that we're treating. And the third variable is our underlying cost. And that's what we base our costs on when we price.
I want to move on to discuss the workforce shortages impacting affordability and access to quality care for patients. The country is facing significant physician shortages that is impacting access to care for millions of Americans. And I, amongst many others, am concerned, as recent commentary suggested, that Congress should eliminate GME funding by formula and replace it with a discretionary grant program, problematically stating that the program supports revenues and not residents. I have partnered with Representative Terry Sewell on this committee to introduce a bipartisan legislation, the Resident Physician Shortage Reduction Act, which would invest in additional Medicare funding to train more residents. Specifically, this bill would add 14,000 residency slots over 7 years, prioritizing distribution in rural and underserved areas, health professional shortage areas, states with new or expanding medical schools, as well as hospitals currently training their resident caps, or training over their resident caps. Dr. Donley, question for you again. Can you explain how this legislation would benefit patients' access to quality, affordable care, and how shifting GME to a grant program would be harmful to physician training programs at teaching hospitals specifically?
I strongly appreciate your support of GME. In 10 years' time, we're going to be 86,000 physician shortage. And we're not going to solve that problem without increasing the GME spots that are available. And so I think it's really important what you're doing and what you're leading around that. We train 2,500 residents, 500 over the cap. As you're well aware, that means those 500, we actually bear the cost ourselves. It's a part of our mission, and we're committed to doing that.
Thank you, sir. I yield back, Mr. Chairman.
Thank you. I now recognize Mr. Kustoff from Tennessee for 5 minutes.
Thank you, Mr. Chairman. Thank you to the witnesses for appearing today. Dr. Donley, if someone presented themselves at your facility for a colonoscopy and they had commercial insurance, would you be able to tell them what the facility fee is within reason?
I personally don't know the facility fee, but our team would absolutely be able to get that information.
In other words, a patient would be able to find out the facility fee if they had insurance.
I believe so, yes.
I mean, it's an important question because the patient's entitled to know, aren't they?
They're absolutely entitled to know, and our intent is that the patients absolutely know the transparency of the cost.
Would the patient know the facility fee if they were on Medicare? You don't know?
I believe they would.
Okay. That's not a yes, though. I mean, we talk about price transparency a lot. That's important to the president. It's important to every patient. And you're unsure whether they would know what the facility fee is before getting the colonoscopy at your facility.
Price transparency is extremely important to us. It's extremely important that patients know that. I will tell you, in my first 12 weeks as CEO, it might not be something that I specifically know, but I know our team would know the answer to that. And absolutely, we are committed to make sure patients know the price.
All right. Well, let's, if we can, I'm going to show you some data from CMS about a colonoscopy performed at an ambulatory surgical center and one at a hospital. And I know that when I believe it was Chairman Smith, asked everybody to raise their hands about the disparity in cost at a procedure performed at a hospital versus a surgery center, you did raise your hand and you said that was acceptable. This shows the cost of a colonoscopy performed at a surgery center owned by a physician or group of physicians. It's $656. That's CMS's fee that they pay. The facility fee at a hospital is almost double that, $1,222. I'm asking this and showing this to you because you raised your hand that you accepted the fact, you set the fees, that the facility fee can be higher than the surgical center fee. My question to you is, and I'll concede that there are some services that you provide that the surgery center doesn't provide outside of the colonoscopy. But is 100% increase in the fee that you charge versus the surgical center, does that seem reasonable to you, to the American taxpayer?
I think there's absolutely opportunities as we look at site neutrality to look where things aren't reasonable. I do think it's important, though, that we recognize when things are done in hospitals, that hospitals compared to a place of not hospital, physician-owned, hospitals will take care of sicker patients. That's more risk, and that's costlier. Hospitals also will take care of all patients that show up, regardless of what their payer is, and that's different than physician-owned places. The other thing is in a hospital place, the third point, there's a higher regulatory burden for a hospital a place opposed to a physician-owned place. Those are costs that we need to make sure as we look at better options for site neutrality that we remember that.
This isn't private insurance, this is Medicare,
Yes.
CMS. Does all that justify a 100% increase in the fee that the facility charges versus the surgical center?
I think there's absolutely opportunities in site neutrality for us together as we look at solutions for affordability, opportunities for it to be better.
Let me ask you, if you're a physician or a group of physicians and you own a surgery center and you see the disparity in what's reimbursed to them versus what's reimbursed to you, don't you look and say, how do I compete against the hospitals?
You know, I think as a physician myself, what we see is the less regulatory burden that's in a physician-owned place opposed to a hospital place. We also, I will tell you, I've personally experienced that in a hospital-owned place, you'll take care of much sicker patients compared to a physician place. There are definitely
My time's
opportunities.
expired, I yield back. Thank you.
Thank you. I now recognize Ms. Moore from Wisconsin for 5 minutes.
Thank you so much, Mr. Chair. I want to know on the panel, I like the raising hand thing, how many of you just are really relieved to hear that we didn't cut $1.2 trillion out of Medicaid, that all we did was sort of clean things up, and that there's, 6 million able-bodied people, probably young people, are not going to show up in your ERs because they're able-bodied and well, 1.4 illegals that we're going to deport, 3 million people who are ineligible and just don't know it yet, and the 5 million ACA Obamacare people who, whatever. How many of you agree that we didn't really cut We've heard RFK Jr. say this, we've heard our members on this panel say that that was not a real cut, we just cleaned up. How many of you believe that? None of you. Let the record reflect that nobody thinks that there was not a $1.2 trillion cut in Medicaid. I am going to come back to you, Mr. Woodhouse, to explain what that is, but I want to ask, how many of you, you heard Mr. Swiker talk about obesity driving, being a healthcare cost driver. How many of you agree that GLP-1s would be very helpful if we allowed Medicaid and Medicare both of these systems to pay for GLP-1s for some of our patients. Do you all agree? All right, fantastic. How many of you, disallowing the provider tax to help draw down more Medicaid, how many of you see that as a problem with regard to your bottom lines? All right. Wow. That's like most of you, all of you except one person. Mr. Lassiter, I have a specific question for you. I read through your testimony with great interest because you seem really optimistic in terms of being able to navigate in this current environment because of how large your system is. But I'm wondering, are you depending on AI and telehealth to navigate these additional costs? On a bipartisan basis, people like telehealth, but I've always been skeptical of it that it may displace care that people need in person.
Congresswoman, thank you for the question, and thank you for acknowledging a sense of optimism in some of my testimony. Yes, I do believe that telehealth is good for the healthcare field, and I do believe that technology and AI has its place. At CommonSpirit, we're strongly investing in AI to support our caregivers in delivering safer care, higher quality care. We're using artificial intelligence to support reducing costs in our administrative areas. We believe strongly that there should always be a human being between AI and the patient, and so we're very focused there. We utilize things like virtual integrated care, virtual integrated nursing to provide support in rural communities where there may not be sufficient staffing to ensure that our nurses are relieved from some of the mundane administrative tasks.
But you don't use AI in lieu of people coming into your facilities. That's what you're saying, right?
Not at this time. That is correct.
Okay, thank you very much. Mr. Woodhouse, there's really a big disagreement about whether or not we cut $1.2 trillion out of Medicaid, and you've heard all these people, every single one of them say that it's going to disrupt their ability to care for patients. These people, the 15 million people, have been characterized as ne'er-do-wells, lazy people, illegals, people who are scamming the system. Can you tell us who these people are?
Well, we've met with them all over the country. I mean, they're farmers. They are small business owners. They're people who are self-employed. They're gig workers. They deliver for DoorDash. They deliver for Uber. And like I said, there are many in the rural areas who are farmers. So look, we know, we've seen in other states. We saw in Arkansas. We've seen in Georgia. We know what a lot of these provisions are about. They are paperwork provisions that are meant to trip people up, to keep them from accessing care and reduce that population, to create money that can then be used for tax cuts for the rich. And that's what happened in H.R. 1.
He's about to drop the gavel on you, so I would yield back, Mr. Chairman.
Thank you. Mr. Smucker, I recognize you for a point.
Thank you for recognizing me. I'd just like to submit for the record a 990 form from CommonSpirit Health relative to questions I had asked in regards to board meetings held outside of the U.S. This has a line item, Canada and Mexico, $85,580 spent on board meetings there, and $78,123 spent on board meetings in Europe. So I'd like to submit that for the record.
Without objection, so ordered.
Thank you, Mr. Chairman.
Now I'd like to call on Mr. Stubbe from Florida for 5 minutes.
Thank you, Mr. Chairman. In Florida, rapid hospital consolidation and vertical integration have expanded the use of off-campus outpatient departments that bill at higher hospital rates, even when care is delivered in settings that look like independent physician offices. Congress recently took a step towards greater transparency by including provisions from the FAIR Act in the January appropriations package, requiring distinct national provider identifiers, or NPIs, for on- and off-campus facilities, aimed at exposing site-of-care billing practices that drive up costs for patients and employers. Congress acted on a bipartisan basis to require separate MPIs so patients and payers can finally see where and how services are billed. Will your hospital systems fully comply in a timely manner, and will you commit to making the data easily accessible to patients? I'll start with Mr. Hazen.
Yes.
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 Thank you. In Florida, patients are often charged significantly more for the same service based solely on hospital ownership of a site. And basically, I'm just going to build on the questions from Mr. Kustoff. Mr. Donley, you already answered that, but how can you justify facility fees on outpatient facilities when there is no meaningful difference in the care delivered or the quality of the care? And I'll start at the other end of the table, Mr. Hazen.
I think there are aspects to hospitals that reimbursement covers beyond just the procedure, and that's 24/7, 365 readiness. It's hurricanes, as you know, in Florida. It's uncompensated care and those components. I do believe there are opportunities to rationalize some of those differences, as I mentioned.
Give me an example. What would that mean?
Well, I think in the ambulatory surgery center discussion, there could be certain procedures that are, the separation between the prices are too significant, and they need to be less because they're not emergency driven or something of that nature. That's just one example.
Is that something that HCA would look at in the next 30 to 60 days and then report back to the committee on any changes?
We would be glad to work with the committee on that.
Mr. Lassiter, same question.
Thank you, Congressman, for the question. I would concur with my colleague to the right regarding why some of the differences exist between hospital-based activities and physician office activities. I would say to you also, sir, that at CommonSpirit, we operate 2,300 care sites. Only 158 of those are hospitals. And so we work very hard to operate ambulatory surgery centers that would not have that site-neutral adjustment. I would agree with the prior comment that we would acknowledge there might be opportunities for modifications in the current site-neutral process. We support the fact that with hospitals having 24-hour coverage, emergency departments, et cetera, that does drive some of the cost differential. But we also, frankly, we open more ambulatory, non-site neutral facilities every year than we acquire new hospitals. So we're very focused on having multiple care sites to ensure that patients in the community have access to affordable services.
Mr. Waldrum.
Thank you. As you know, we have a federal mandate to care for anyone who shows up to the hospital. We have a moral obligation to do this. We're the only participants in the healthcare value chain that have that obligation. Doctors, nurses, insurance companies, drug companies do not share in that obligation. In order to provide access to rural care, HOPDs help us recruit physicians and support the workforce to maintain that critical access.
So you're saying because of that federal requirement, it's going to cost more for you to provide the exact same service as it would at, say, an ASC?
We do not provide the exact same service. We care for more complex patients, and it's the only service.
Yeah, but just like what Mr. Kustoff was showing.
We don't operate in New York City. We operate in rural North Carolina. And so in order to recruit and provide access for cancer care and other services, as mentioned, we're willing to look at it. We would like to work on some rational reworking of how that works, but these payments are essential in providing access to care for rural Americans.
So you're saying in your hospital system, if somebody went to a private provider at an ASC for the same surgery, that it would be the same price? Or you're saying that it would be different based on the federal mandates that you have to treat everybody?
I'm saying what we've talked about is that we have a problem with workforce and having doctors and access in rural environments. There is no alternative access points, and no one is coming to rural America to set up those practices.
My time's expired.
Thank you. I now recognize Ms. Tenney from New York for 5 minutes.
Thank you, Mr. Chairman. Thank you for holding the meeting, and thank you to the witnesses for being here on this very important topic. I've heard the Democrats on this committee and their witness, Mr. Woodhouse, absurdly framing the affordability crisis as a result of H.R. 1. Well, as a New York resident and a New York business owner, I can tell you this healthcare affordability crisis has existed for years in my state, and it lies solely at the feet of Albany bureaucrats, which for decades have saddled working-class families and small businesses with exorbitant taxes on private insurance. The truth is that Kathy Hochul and Albany Democrats, and I served in the state legislature, operate a healthcare financing system that extracts at least $6.6 billion in hidden taxes from working families for their health insurance, maximizes federal cost shifting to cover their own budget failures, and insulates powerful institutions from accountability, all while calling itself a model of progressive governance. The result is the #1 highest employer-sponsored health insurance premiums in the country. Not second highest, first. $9,589 for single coverage, $27,188 for family coverage. And I have a family business, and we are now paying in excess of $30,000 for a family in rural upstate New York. There are 15 to 20% higher than the national averages, and just think of what our small family business does, founded by my grandfather, who, by the way, founded a community hospital in the little hamlet of Hamilton, New York. And the state just approved premium increases from 7 to 13% for this coming year. Now, Mr. Waldhouse, I heard a little bit of his testimony, is not a physician. He's not trained in healthcare. He's a political operative and worked with President Obama to create what I think is one of the worst things that's happened to our country and our small business community, and that's the ACA, otherwise known as Obamacare. Mr. Woodhouse, you said in your testimony that there are 5 hospitals in my district, New York 24, that are at risk of closure because of H.R. 1. I have no idea where you got that idea, and I question the credibility of your source on that. But I can tell you every hospital in my district, and probably every hospital across the state, makes up the difference from commercial payers becoming fewer by the year because of the Albany Democrats and their disastrous policies and what's happened since the advent of the Obamacare system. So, Mr. Woodhouse, you came here today to talk about working families being squeezed. So did those families know they were paying $1,760 a year in hidden Albany taxes on top of their already skyrocketing premiums? Is your organization advocating to reduce those taxes? That's a rhetorical question. Do you believe that collecting $6.6 billion a year in hidden taxes on health insurance, including a covered lives assessment for the professional education pool, the state-run GME program that hasn't been funded since 2008, preceding Obamacare, lowers premiums for working families and small business owners and employees? These taxes hit a mechanic in Oswego, my home county, the exact same way they hit a Wall Street executive in Manhattan. So Albany built a public coverage program that was bankrolled off in exorbitant subsidies for non-citizens, priced private insurance out of competition for nearly 10% of the state's population. Is it progressive to pull healthy people out of the private risk pool, concentrate the sickest and most expensive patients in what's left, and then call the resulting premium an explosion of a federal problem? This is a New York State problem that is on top of a huge federal problem created by Obamacare, not H.R. 1. Mr. Woodhouse came here to tell this committee that Washington is responsible for America's health care affordability prices. But New York Story tells you different, and everything you need to know about where that framing breaks down. Albany created a tax in 1996 to fund doctor training, aside from the fact that our state is already the #1 beneficiary of federal GME funding. They killed the program in 2008 and kept the tax. They created a coverage mandate and diverted the revenue. They built a zero-premium public program on federal dollars tied to a 30-year-old eligibility rule with no contingency for the day that rule was reasserted, and called it sustainable. They layer mandate after mandate onto private insurers every single session and private employers. They run an indigent care program that sends more money to well-resourced hospitals than the safety net institutions in my communities that actually serve the poor. And they have been doing all of this for decades while presiding over the highest employer-sponsored health insurance premiums in the country that is bankrupting our employers across New York State. New York is not an outlier. This is a preview of where the Democrats' healthcare policies will lead us. And I agree with Dr. Murphy. The dream of Medicare for all is absurd. We have to stop this nonsense now. Affordability is because of the ACA and because of states like New York. I yield back my time.
Mr. Byer.
Mr. Chairman, thank you, and thank you all very much for being here. I get to co-chair the Bipartisan Mental Health Caucus, and we're all deeply concerned about it. And just because of your important roles, I'd like to dive deeper. I know we see emergency departments are an increased number of people with mental health. Think the teenagers in ERs waiting days for a bed. We have this challenge with boarding and trying to improve early intervention. I represent Inova, large hospital chain here in Northern Virginia. They established an empath unit recently, specifically designed to provide emergency care for adults experiencing a mental health crisis. Arlington County, right across the river, established a mobile crisis team. We funded it with special project funding, making a significant difference. But Dr. Donley, I'm particularly interested in what New York-Presbyterian is doing on mental health with early intervention, with improved access to care, and with support care coordination. What happens when they get out of the hospital?
Congressman, thank you very much for the question, and thanks for your support towards mental health. As you state, it's a glowing problem in America that we must face, and it's a big source of the cost of care. At New York-Presbyterian, we're proud of our commitment to behavioral health. We have 500 inpatient beds. We're one of the largest providers of behavioral health services in New York. One program that recently we found very beneficial is we work with a nonprofit government organization to do patient navigation. And so when patients come into our emergency rooms, we screen them for housing insecurity, we pair them with our partner, and are able to find housing for them. This is not only great for the patients themselves, it's obviously great for their families, but it also is great for taking out the cost of care, because otherwise these people across the country are frequently using the emergency room. We've already been able to help 200 patients like that using that program.
Great, thank you very much. Using Mr. Lassiter's statistics, Dr. Waldrum, he talked about 141,000 physicians short, 70,000 primary care physicians, the shortage of psychiatrists, especially child psychiatrists around here. When you look at the cost of college, like a Virginia public school, like James Madison, UVA is going to be pushing $30,000 a year. You talk about medical school, especially with the loan cutoff now at $50,000. How do we address this long-term physician and nurse shortage, especially with the extraordinary cost it is to move them through? And let me throw out my favorite thing. Why do we insist on a 4-year college education for physicians here when they don't throughout Europe, where the medicine is very good?
So thank you for the highlighting a very important issue. As we've mentioned, and I've mentioned, workforce is a major driver of healthcare costs, and we have to increase the pipeline and make the pipeline more efficient. So cutting off, and we built pathways to decrease the level of education, so a year of college off, and then we're looking at 3-year programs, and then for GME, and specifically for behavioral health, so graduate medical education, and looking at how we can be more efficient for the pipeline. Because as you mentioned, it takes 10 years to create a physician, and so the glide path of that is long. And importantly, this expansion of GME, as we all cover an extreme amount of that workforce development and graduate medical education. I'm very proud of the school at Brody School of Medicine of ECU. We have one of the lowest debt rates coming out. We've structured our pipeline to increase the yield for primary care and for rural environments. We've had investment in rural residency training programs, and we can show a direct return to those communities with over 70% retention. So that's built into the way we recruit and then train our doctors for the specific environments that we serve.
Great. Thank you very much. Mr. Hazen, run a big system. We know that administrative costs, I think NIH said administrative costs are 17% of total hospital costs. You got to fight overpayment, recovery requests, all kinds of things. What do we do about payment friction? What can we do to reduce the administrative costs in hospitals?
Thank you, Congressman. That is one of the areas where we see opportunities for the patient, opportunities for providers, and really for the system as a whole. I think digital integration between payers and providers is a very significant opportunity. We, in fact, are working with some of the major payers on that very effort, and I think we're, as I mentioned in my opening comments, making progress. The idea of regulations and regulation overlap and conflicts also complicates the whole administrative processing of claims. I think there are opportunities there. We've discussed a few of those today. Those are areas. And then I think using best practices, innovation, new technologies like AI to improve administrative activities is going to be helpful.
Thank you very much. I yield back, sir.
Thank you. Ms. Van Dyne.
Thank you very much, Mr. Chairman. As we examine healthcare affordability today, American families are getting squeezed from every direction. Premiums keep rising, but so do the underlying costs, especially hospital prices, which now account for the largest share of healthcare spending. Just a few months ago, we were having the same conversation when this committee brought in the CEOs of the largest health insurance companies. A lot of commitments were made in that hearing about lowering costs and working with Congress on solutions, and it's been interesting to see what's happened ever since. Of the 5 CEOs who testified, only 1 has continued to actively engage with my office to follow up on these commitments. So that gap between what's said in a hearing and what actually happens afterward is part of the problem. And until accountability matters, you're going to see this problem grow rampant across the entire system. That's why I've been leading legislation to repeal the federal restrictions on physician-owned hospitals. And right now, Washington is effectively blocking the expansion of facilities that often deliver high-quality care at lower costs. And these restrictions protect incumbent systems and limit patient choice. We should not be protecting consolidation. We should be encouraging competition. And physician-owned hospitals can help bring real market pressure into highly concentrated areas, lower costs, and expand access. But today, they're essentially frozen in place by outdated federal policies. That needs to change. And this issue goes beyond providers. I hear constantly from constituents who are trying to buy coverage on their own that they only have 1 or 2 options, all of them are expensive, and no meaningful ability to shop for anything that actually fits their needs and their budget. So affordability is not just about the cost of care, it's also about the people, whether or not the people have access to coverage options that work for them. So Dr., is it Hazen or Hazen? I want to make sure.
Hazen, no doctor.
Hazen, okay. I want to make sure that we're saying your name correctly. Physician-owned hospitals expand access, they lower costs, and they serve a broad patient population. What are your specific concerns with that model?
Congresswoman, I'm glad you raised that. I've had 43 years in this industry. I've seen physician-owned hospitals operate. I've seen them close. And so I think we're all for competition. We're all for competition with physician-owned hospitals. However, it has to be level playing field. In my experiences in the past, that's just not the case. They don't have functioning emergency rooms. They don't take care of uninsured Medicaid patients, and so forth. And so you have a difference in competition in that it's not level and balanced, and there are conflicts. And so I think if we can harmonize those factors and make sure that all aspects of the system are competing on a level playing field, that could be productive.
Don't you see that some of the hospitals also cherry pick their patients? I've got an article here that shows that babies will no longer be delivered at Research Medical Center. This is an HCA Midwest Research Medical Center in Kansas City, that you actually stopped seeing labor and delivery patients. Don't hospitals do that too?
Well, Congresswoman, we have 33,000 patients in a bed today. 90% of them presented to our emergency room first. So 30,000 of them came through our emergency room. We're not cherry picking patients when 30,000 of the 33 come to our hospitals.
All right, thank you. Mr. Lassiter, and really all of you, this is kind of an open question. There's been a lot of discussion about how the administrative burden is driving up costs. We've all seen the charts where you see the growth in physicians, the people who actually touch the patients are pretty much level, but the administration has gone up like multitudes. That's contributing to burnout, and it's not improving patient care or the patient experience. It's really only increasing costs. From your perspective, and I want you to be as specific as possible, what federal requirements should we be targeting to meaningfully reduce that burden?
Thank you for the question, Congresswoman. I'd say a few things. First and foremost, the quality reporting is one area that I would that I would specifically focus on, there is significant overlap in the requirements to report, which creates significant issues. At CommonSpirit, we're working on trying to reduce some of that burnout that you described by investing in, for instance, ambient scribing, which allows...
I'm not asking what the hospitals could do. I'm asking what federally, what requirements that we should be looking at that we can scrap that would help reduce the costs.
Thank you for the clarification. So I would say that I do believe that our administrative burden is tied very much to what we have to report on, what we are regulated on, the agencies that have overlapping jurisdictions that require that kind of multiple reporting on similar issues. Those are the kinds of things that I would point to.
And I see everybody wants to jump in, but I'm already over my time.
I would love to see supportive policy to protect the safety of healthcare workers. You mentioned burnout. There's an alarming increase of violence against healthcare workers. And so policy to protect those workers. We spend $120 million on physical and cybersecurity every year.
Excellent. Thank you very much. I yield. Oh.
I think it's important to just put this in context. For MA alone, there's 3,700 MA Advantage plans. With our beneficiaries can choose 42 different plans, and they all have, with 9 different carriers. And they all have different reporting rules. They all have different prior auth rules. They all have all these administrative burdens. So in the clinics in rural America, that's what we have to train our staff on, and that's what we have to submit the data on. That is an extreme expense that we have to incur.
Mr. Feenstra.
Thank you, Chairman Smith and Ranker. Thank you for holding this hearing. We've talked a lot about affordability. I am from rural Iowa. I sat on an executive board of a small rural hospital, and it's different than urban centers. I know we all talk about the hub and spoke model. I get it. I mean, we are a spoke to one of the big hubs in Sioux Falls, South Dakota, or Des Moines, or Sioux City. But I want to talk a little bit about how we can maybe look at affordability different. Mr. Hazen, you noted that affordability is a barrier to care. We all get that. And the starting point is insurance coverage. So I want to ask you, what happens if somebody doesn't have insurance coverage but wants to pay straight cash? What is their discount? And the reason I'm asking, well, let me ask you that question first. What is their discount if they want to pay straight cash?
Congressman, I can't give you a specific percentage because it varies by hospital, it varies by service.
Right. 10%, 5%, 20%?
Oh, no, it's way more than that.
Say it again. It's way more than what?
10 or 20%.
Yeah, it's way more than 20%.
Right.
All right. I just want to think about this. So the average hospital charges commercial insurers about 250% of Medicare rates. Okay? So you really have the insurance people, all right, people that are carrying the insurance are really covering for those that are using Medicare. Is that a fair statement, Mr. Hazen?
There is cost shifting that occurs.
Cost shifting, yes. So this is the problem with just the common family. All right, their child breaks a leg, they have an HSA, all of a sudden they got a $10,000 deductible, and that broken leg cost $8,000. All right, so they pay $8,000 out of pocket, but here's the problem. They don't get the cash discount because they're going through the insurance company, and HSA still has to go through the insurance company. So the insurance company has to do all the pre-authorization, all this other stuff. Why can't we get rid of the insurance company and say, let's just do cash base and create an account for somebody that can grow tax-free like an HSA and not having all this other red tape involved? Dr. Donley, what is your thoughts? How do you handle your cost accounting when it comes to somebody that wants a private pay and pay cash?
We have a process in our finance department for patients that would want to pay cash, and they do receive a discount off the listed price.
How much?
I don't know the exact amount, but
it should be significant, right?
Yes.
Okay. What I'm trying to get at is the cost of having health insurance and you using health insurance, and you just noted it, Dr. Waldrum, about Med Advantage plans and all this stuff. I mean, there's bureaucracy that's incredible. So when you move the bureaucracy off to the side and say, hey, I'm just going to pay cash, you can dramatically lower your cost of affordability. And I just look at the government saying, if this is what we want to do, then you just do it tax-free and say, you put this in a tax-free account, not an HSA, because an HSA is, again, tied to a health insurance company. It would work a lot better. All right, I'll get off my high horse. To me, it's sort of important. I want to talk to you, Mr. Waldrum. Thank you, by the way, for what you wrote in your testimony. Maternity units are closing at an alarming rate. I did my doctorate in this very vein, showing that maternity units are closing at this crazy rate, and we're seeing dramatic increase in infant mortality. And the problem is, as you noted, is we have less births, and the costs and med malpractice, and there's a lot of other things. So in the hub and spoke model, you noted that we're also seeing, you can give early care, but you still need a main hospital to have maternity care. How do we change the system where we get more these spokes to have maternal care and maternity unit care?
So I think it's important to understand the hub and spoke model. We operate all of our hospitals as one conglomerate whole, and we understand our population, and we match the needs of the patient to care locations and keep it as close to home. I have 5 hospitals in very remote rural organizations that we maintain maternity units, and AI will not deliver a baby. And so I pay doctors and nurses and drug companies to catch 1 baby or maybe 2 babies a day. They don't come that way. They may come 5 a day. Yep. And we know that if we close those units, that more moms and babies die in rural America. So we take the profit from the academic medical center that is in a rural community called Greenville, North Carolina, and we cross-subsidize it because that's what a mission-based
time is up. I yield back. But you nailed it. You absolutely nailed it, that we're having higher infant mortality rates and mom mortality rates. It's sad. Thank you. I yield back.
Mr. Evans.
Thank you, Mr. Chairman. Congress is not addressing the priorities right now. Premiums in Philadelphia have drastically risen over the last year, an increase of 116%, causing severe financial stress on many of the residents of the city. One of my constituents is a musician and an independent contractor. He says when the ACA subsidy went away, his monthly premium went up by over $600. He is now paying over $180 a month. That's 1/5 of the income on the health insurance. He's not counting on co-payment and prescription. The ACA is not a perfect system, but making people who are financially struggling to bear the burden of health costs is unfair. Mr. Woodhouse, what would you say to people experience what my constituents describe, especially when they have to choose between health care, food, and housing?
Well, I think it's something that in the stories that we've been collecting that we're seeing, and there are lots of really tough choices. We have a woman who Teresa Acosta in Georgia, who had her own business, and then had these exorbitant healthcare premium increases as a result of the ACA tax credits going away. And it's similar to another story that I recounted earlier, where she's now got to go find a job that has insurance. She cannot afford her own premiums on the marketplace. And we're seeing this with farmers, we're seeing this with small business owners, we're seeing a lot of really tough decisions with the Medicaid cuts coming with caregivers who are thinking about what is the access that they're going to have to nursing homes. But by the way, these people are not just facing affordability crisis in healthcare. Let's talk about eating. Let's talk about the cuts that were made in H.R. 1 to SNAP and that were made to food assistance. And then we talk about a healthy diet. Vegetables are more expensive today because of tariffs and because of all of the inflation that we've seen since Donald Trump came into office. And so they can't eat healthy. They're having a hard time accessing health care, having a hard time accessing the premiums. It is a lot of things coalescing on an affordability crisis on Americans all at once.
Dr. Dooley, how is your hospital committed to offering low-cost health insurance plans for consumers and employees? Dr. Yes.
I'm sorry.
Good. Yeah, how is your hospital committed to offering low-cost health insurance plans for consumers and employees?
We have a strong focus on our employees. We have 45,000 employees who are dedicated to taking care of our patients every single day. And in order for them to be great for our patients, we realize our priority is to make sure that we put a priority on them. And so it's around their insurance, it's around healthy food, it's around mental health. We have a lot of support programs for them.
Let me go back to Mr. Woodhouse. How does a growing number of uninsured and underinsured patients impact our strained healthcare system?
Well, I think these gentlemen might be more qualified to answer that than I am. But I think one of the things you've heard here is about uncompensated care. I mean, I think there's a member over here blowing off 15 million people losing access to health care. But as those people lose access to health care, I think what you've heard is there are a lot of emergency room visits. Those emergency room visits are not paid for. Those costs are borne by other people on employer insurance, by other parts of the system, not to mention the fact that we're seeing states and localities that are really struggling with are they going to allow this calamity to happen? We've seen people are raising property taxes. I mean, I don't think the people in those counties, I don't think those county commissioners want to raise property taxes, but they don't want to see their hospitals closed. So it does cascade.
Chairman, I'd like to yield back. That's my time.
Thank you, Mr. Hearn.
Thank you, Mr. Chairman, for holding this very important meeting. Thank you all for being here today. It's obviously a very hot topic among all of our constituents, no matter what side of the aisle you're on. Just a yes or no question, just so we have you guys on the record. As we go across, starting with you, Mr. Hazen, are you for Medicare for all, just so all of our colleagues here know that?
No.
Okay. Mr. Lassiter?
No, sir.
Donley?
No.
Waldrum?
No.
Woodhouse?
It's not a yes or no question.
Nice answer. Every one of us here today have heard from our constituents expressing the concern over rising health care cost. Since 2000, hospital prices have grown nearly 300%, vastly outpacing inflation and wages. In fact, hospital prices have grown more than any other part of our economy, and no one really knows how these prices are calculated. While most individuals are not directly exposed to true hospital prices, these are not just abstract costs in the ether. These costs are passed directly on to patients, whether it's in the form of cash prices or higher premiums or out-of-pocket costs. I would like to follow up on some of my colleagues' comments regarding site neutrality or the lack thereof. The reality is that federal payment policies and billing practices such as site of service pricing have enabled wide variation in prices that often bear little relationship to the actual cost or quality of care. Hospital systems being allowed to charge more for the same services has led to consolidation in the system, with hospital systems steadily acquiring more independent physician offices and outpatient facilities, reducing competition. Data has shown that when hospitals acquire physician offices, patients pay up to 4 times more than the same exact service done in the same exact place by the same exact doctor. I have one CEO said, I can't explain why that is allowed, but that's just the way the system works. And again, this is not just a data game. I've heard from patients directly in my district that have seen this happen and want answers. Their doctor hasn't changed, their health status hasn't changed, the building hasn't changed, just the ownership changed and the price. For all of the witnesses here today, If you all won't commit to supporting site-neutral payment policies, how will you ensure patients will not be subject to price increases at their physician offices after they are bought up by your hospital systems? Any thought, Mr. Donley, Dr. Donley?
I just think, say, as a strategy, we do not purchase physician practices and turn them into hospital sites. That's not a part of our strategy.
I would say the same thing.
I would concur with that, Congressman, that we do not buy practices to convert them to site neutral.
Mr. Hasan?
We don't do that at all.
Okay. So continue on the disparities between independent physician offices and hospital systems. I want to talk about tax status. Many large health systems operate as tax-exempt entities and are subject to the same requirements to maintain their tax-exempt status as independent providers. Given the differences between these large corporate health systems and smaller independent providers, I imagine the IRS reporting varies as well. Dr. Donley, solo providers report their community benefit spending based on its individual facility. Do large systems like New York-Presbyterian report community benefit spending on a facility-by-facility basis, or does the hospital report all of the community benefit spending across all the facilities on one Form 990?
We report following the federal guidelines as one facility.
Okay. So how can the IRS determine if an individual facility is satisfying the community benefit standard if no information is reported about the community benefit spending by the individual facility?
You know, I think that would be a discussion we'd be happy to have. As I said, right now, the federal guidelines have us reported as one facility.
So you would have no problem then being able, a very large system, if you're in a rural community or outlying community, you'd have no problem reporting a different 990 for that particular area as you're looking at how your community benefits compare to some other independent provider.
You know, I think it would take a lot of work. We'd have to work through that to see what the process is.
But it would probably be well worth it for a tax-exempt status, right?
I think tax-exempt status is very important. You know, we have a $2.4 billion community benefit. Our tax-exempt status is a benefit of $622 million. So our community benefit right now is 4 times what the tax-exempt status is for us.
Yeah, you would. I obviously haven't looked at your financials, and I'll take you at your word since you're testifying here. But that's not the case for all. When you look at the tax-exempt benefit for many hospitals across the country, where their tax benefit, whether it's local, state, or federal, doesn't meet that same community standard, which is, by and large, one of the reasons the tax-exempt status is questioned from time to time, or quite often, actually. So again, maybe you're the model for the rest of the country, or for maybe everybody else that's up here. But it's certainly a real problem for many communities across America, and that's why they get questioned. And so I think that as we go through this process, we appreciate you being here. We appreciate all of you all and bringing forth your information, and it'll help us make better policies in the future. Thank you, Mr. Chairman. I yield back.
Thank you, Ms. Miller.
Thank you, Mr. Chairman, and thank you all for being here today. It's been quite an interesting discussion. Mr. Woodhouse, in your written testimony, you mentioned my district and the decision of Greenbrier Valley Medical Center to close their labor and delivery unit. You specifically cite this closure as being caused by H.R. 1, which you make it sound like it's the boogeyman, but that is false. It is a false statement. Vandalia Health, the owner of the hospital, has said themselves that the closure is a recruitment issue and that the hospital had tried for over 2 years unsuccessfully to recruit a physician for their delivery room. How could this possibly be an issue caused by H.R. 1 when the hospital's been unable to recruit physicians to staff its labor and delivery unit for over 2 years, well before this legislation was ever under consideration? Recruiting and maintaining physicians is only one of the many challenges of rural hospitals. I'm from West Virginia. I understand this issue. Another issue impacting tax-exempt health systems involves the classification of the hospital itself. I'm disturbed at the trend of rural hospitals getting taken advantage of. As we know, hospitals classified as urban receive higher Medicare payments, whereas hospitals classified as rural benefit from other things like easier access to 340B program and 30% more graduate medical education funding. That said, an increasing issue in recent years has been the dual classification of some tax-exempt hospitals as both rural and urban, seemingly taking advantage of a Medicare loophole in order to receive lucrative financial benefits. That's why I joined with my colleague Congressman Taylor in introducing the Defend Rural Health Act. My bill safeguards federal resources intended for rural hospitals and the communities that they serve. It closes the long-standing loophole that has allowed large urban hospitals to simultaneously classify as both urban and rural, enabling them to improperly access benefits reserved for rural providers. Dr. Donley, I understand that 8 of New York-Presbyterian hospital campuses are classified as rural despite the proximity to New York City. Can you explain this to me? I mean, do you think New York-Presbyterian is a rural hospital?
First of all, thank you very much for your advocacy of rural health care. As a physician myself, rural health care is critical to the health care of this country, and we all need to focus on making sure that rural health care remains strong. At New York-Presbyterian, we do not consider ourselves a geographically rural hospital. But under CMS, we are designated as a rural referral center, and we are proud of the thousands of patients from rural America that come to us when there's nowhere to turn for a problem that they have. We're also proud of the 2,500 residents that we train, 65% of which leave after their training to go across America, including rural America.
I'd love to know that percentage of how many of them really do go to rural America after being in a big city. I understand that reports have also surfaced that New York-Presbyterian provides Chanel gift bags as its maternity hospital. Is New York-Presbyterian using the lucrative financial benefits received due to its dual classification to buy luxury handbags instead of lowering costs for their patient care?
We absolutely are not. Those are donated, and they're donated by the company's foundation, in addition to further philanthropic support that company and their foundation gives to us to support a 4th trimester program to take care of all mothers and all children in the first 12 weeks after being born, which is, we all know, is a critical time.
That is really good news. I thank you. Do you want any more time? I yield back my time. Thank you.
Mr. Panetta.
Thank you, Mr. Chairman. Gentlemen, thank you for being here. Appreciate your time to discuss, obviously, the many issues in our healthcare system that are deeply important, not just to all of us up here, but to our constituents back home. And I think that's the main point as to why we're here and these issues that we're talking about. Look, for me in the 19th Congressional District, I got a lot of senior citizens, and the #1 healthcare issue for them is not coverage, it's access. It's the delay they constantly face when accessing care through their Medicare benefits. When I talk to doctors as well, I hear similar concerns. Medicare Part B is not keeping up with the cost of providing care. When I talk to these physicians, they tell me they are struggling to hire and retain staff as demand grows. And they tell me that they spend as much time in 1 in 5 working days fighting Medicare Advantage prior authorization denials, time that should be spent caring for their patients. That's why when it comes to health care, there are a number of issues, but in California's 19th Congressional District, fixing the payment system is a priority. Reimbursements have to reflect inflation and the real cost of keeping a practice open. That's why I've introduced legislation with my colleagues on this committee to address this shortfall. More recently, I partnered with some of you to pass legislation which cracks down on Medicare Advantage ghost networks. Last week, we built on that success by introducing the Medicare Advantage Improvement Act, a common-sense bill that directly addresses the challenges that my constituents face by speeding up Medicare Advantage approvals, bringing transparency to the prior authorization process, requiring timely payment to providers, and limits post-authorization denials that lead to surprise coverage losses. As you've heard today, there's a lot to discuss about the healthcare system overall, but selfishly, as a representative of the 19th Congressional District, I want to focus squarely on issues that affect my constituents that they live with every single day and what together we can possibly do to fix them. I represent the Central Coast of California, 19th Congressional District, San Jose, Santa Cruz, Monterey, down the northern San Luis Obispo. A pretty big, diverse, dynamic district. We got a lot of beauty and bounty, and as I said, we got a lot of senior citizens who like to retire there. In Santa Cruz, though, we got one hospital, Dominican, part of CommonSpirit, which Mr. Lassiter, you know well. It's a lifeline for that community with an aging population, more than 52,000 Medicare beneficiaries. Mr. Lassiter, I'm going to tell you, and gentlemen, I'm going to focus mainly on him and not going to ask you any questions, especially in my limited time, so you can kind of zone out after the hours that you've been here. But Mr. Lassiter, you're up. Government payer rates, how do they impact Dominican in particular?
Congressman Panetta, thank you for the question, and also thank you for representing the district where we offer one of our facilities. Generally speaking, the answer to your question is this. Medicare reimburses us below our costs to provide care to patients in your community. On average, it's about 80% of our costs. The Medicaid program also reimburses us below our costs. And as a result, that challenges the sustainability and profitability of organizations like Dominican in your district.
And what are your contingencies, if any?
Well, I think we've talked a bit today about the issue of cost shifting, frankly, and that for CommonSpirit, more than 2/3 of our patients are Medicare and Medicaid, and so we rely on reimbursement from commercial insurance to make up for the lack of reimbursement that we receive from governmental payers.
Now, the bill I'm working on to reform Medicare reimbursements, including indexing Medicare Part B to inflation and requiring Medicare Advantage plans to pay 100% of previously authorized services, speed up authorization approvals, and ban retroactive denials. Can you give us a sense of how those policies would impact seniors' access to services via Medicare?
Thank you for the question, sir. I would say a couple things. For senior citizens, one of the bigger challenges are senior citizens who are the recipients of Medicare Advantage coverage. When you talk about issues related to pre-authorization, denials, after positive authorization, and then frankly, payment by hospitals and systems like CommonSpirit for services we've delivered to your constituents. We don't get paid regularly or timely. I mentioned earlier today, sir, before you came in, that we have about $4.3 billion of unpaid Medicare Advantage claims that we are fighting to receive for care that we've delivered to constituents like yours. I shared with the committee that more than $1 billion of those unpaid claims are more than 150 days old.
Great. Thank you, and I've run out of time. We have more to talk about. We can do that later. Thanks to all of you gentlemen for being here. Thank you, Mr. Chairman.
Mr. Carey.
Thank you, Mr. Chairman, for bringing this the attention to this very important issue, and I want to thank all of you for being here today. I'm going to start my remarks today talking about the ACA. In January 1, I, with my colleagues, many of my colleagues, voted to extend the enhanced ACA subsidies to help keep more Ohioans insured. Now, while I wish that our Congress would have been able to reach a bipartisan agreement on this issue, ultimately, we were unable to do that. Now, I support President Trump's great health care plan to reduce insurance premiums and to maximize price transparency. Mr. Hazen, yesterday, HCA Healthcare released its 2026 Q1 financial reports. Now, within that, and I may need to put on my glasses because we're looking at this today, I read that the expiration of the ACA enhanced subsidies cost HCA about $150 million. However, HCA still brought in a net income of $1.6 billion, or 8.5% of the revenue. So I'm going to ask you this question. Can you speak to the impact of the expiration of the enhanced ACA subsidies on the prices that HCA facilities charge or negotiate with payers? Have they increased as a result? You're up.
Thank you, Congressman, for bringing up the idea of coverage. I think coverage is fundamental, as we've indicated here today. For us in the first quarter, speaking to that, we did see a decline in covered lives in our facilities. Overall, we saw a 15% increase in uninsured patients across our system as a whole. As it relates to pricing, I would submit that there has been no effect on pricing as a result of that change in payer mix.
So no effect on the pricing. So I'm going to continue with you. In your written testimony, you referenced that HCA Healthcare provided approximately $4.5 billion in uncompensated care, including charity care and financial assistance for uninsured patients, and this is just last year. A topic that I'm also interested in is the charge master pricing. So although these are not the prices, obviously the patients tend to see uninsured patients or those whose lost coverage after the ACA enhanced subsidies expired, and those to whom you are providing this uncompensated care are the patients most likely to see these prices. Do uninsured patients, the most financially vulnerable, receive these charge master prices, the highest possible, and then receive financial assistance to bring down their costs?
Congressman, the $4.5 billion that we refer to is actually the costs that we incur to take care of those patients who are uninsured or charity. We have a very robust financial assistance program, including our charity policies for patients who don't have insurance. And for those who are completely uninsured, we have a very significant discount, uninsured discount for those patients.
Okay, and the next question is going to be a yes and no, so when I make the statement, you can think about this. These charge master prices are not directly connected to the cost of care. They are inflated to raise the bottom line. Am I correct? Yes or no?
No.
So how do you calculate the charge master price in total then?
Well, the charge master, connected to the point I made in my opening comments about regulatory modernization, is an artifact from 50 years ago. And so the requirements that we have as hospitals is to maintain a listing of charges. So that listing is not entirely connected to the reimbursement. So 80% of our patients are determined by either Medicare, Medicaid, or some other government programs in our company, and the balance is largely commercial contracts with large payers.
Real quick, so if the answer is no, so what really is the point in having these inflated prices if the patients don't even see them? And you got 13 seconds.
As I said, it's an artifact from 50-year-old regulation.
Okay, I want to thank the chairman, and I want to thank the witnesses again. With that, I yield back.
Ms. Malley-Takis.
Thank you, Mr. Chairman. I want to thank you all for being here today. Look, this is obviously a very important issue because we're talking about the affordability of health care and making sure that our hospitals stay viable, that they're able to provide the care that's necessary in our communities. Over the past 2 decades, the cost of health care premiums, prescription drugs, and hospital services has risen significantly, and these increases are driven by a range of factors, including reduced competition, growing consolidation across the healthcare market, misaligned or overly burdensome government policies such as the Unaffordable Care Act, and bad actors who exploit the system to maximize payments from these federal programs. Since 2000, hospital prices have increased by more than 280%, and today roughly 1/3 of U.S. healthcare spending goes to hospital care, totaling approximately $1.6 trillion in 2024. And as leaders in some of the largest hospital systems in our country, you all play an important role in helping shape the healthcare costs, and we must work together to identify these solutions that can make things more affordable for patients while also ensuring that taxpayer dollars are spent responsibly. Hospitals are essential institutions. They provide life-saving care. They serve as major drivers of economic activity and employment in communities across the country, including in my own district. My district, which is Staten Island and Brooklyn in New York City, has 3 hospitals in very different circumstances. One is an independently owned safety net hospital that serves a large, low-income population and often faces financial challenges. Another is part of a larger New York-based health system and operates a robust medical educational program. And then there's a third hospital that serves my district, and it's in the process of being acquired by New York City's public hospital system. So each of these facilities provides quality care to my constituents, and all are top of mind as we consider legislative reforms. And as we work to bring more affordable services, it's critical that our policy decisions do not create unintended consequences that could undermine the ability, your ability to serve patients. So first I want to start off with tax-exempt status reforms. Nonprofit hospitals receive a significant tax benefit, and in return, we expect them to meet certain obligations. However, those requirements are relatively broad and fall under the community benefits standard, which includes operating an emergency department, maintaining a governing board, and investing in facilities or private care, among other standards. But Dr. Donley, first of all, I want to say you're a top-tier hospital. We appreciate the work that you do in New York City. You've been recognized by many publications and accredited organizations. And you know, when we're examining ways to strengthen these nonprofit requirements, such as setting minimum levels of charity care or patient care investments, can you explain how your hospital system meets the community benefit standard, particularly in improving patient care and helping lower costs for patients?
Yeah, thank you, Congresswoman, and thank you actually for your thoughtful support of hospitals and balancing the different issues to make sure hospitals continue to be strong for your constituents and certainly for our patients. You know, for a community benefit, we have a $2.4 billion community benefit. The tax-exempt status benefit that we receive is $622 million, is what we estimate. A bulk of that community benefit is our commitment to take care of patients who are insured by Medicaid. We are the largest provider of Medicaid services in the state of New York for transplant services and pediatric services, and we're the second largest provider in the entire state for emergency room services. In order to provide that care, it's at a shortfall of nearly $1 billion over the year, and that's a big part of our community benefit. It's core to who we are as an organization, and it's been core for 250 years that we've been in existence.
If this committee was going to establish a minimum for charity care or patient investment, how could we design those policies so we avoid unintended consequences, especially for safety net hospitals that we represent that are already struggling financially?
I certainly can speak for New York, where Medicaid was expanded. In New York, there's only 5% of people that don't have insurance. So I think as we look at making sure hospitals do live up to the community benefit that they should, it's important to look at not just the charity care, but also the care provided to patients who are insured by Medicaid.
Okay, and then when we look at site neutrality policy, your hospital, as well as some in my district, they operate outpatient facilities. Is there a way to tailor site neutrality payments so that patients benefit from lower costs while still preserving access to specialized care close to home?
I think it's important to look at what the options are around site neutrality, but we must always recognize that a hospital place to take care of a higher acuity of patients, you also take care of all patients, regardless of what their insurer is at hospital sites compared to physician-owned sites, and there's also a higher regulatory burden for hospital sites.
So those things should all be considered as we move forward in deciding what type of facilities have the site neutrality payments?
Yes.
Okay, and I want to just say, you've only been the president and CEO for 3 months. You've already come before a congressional hearing, and you've done a good job today. So thank you and congratulations.
Thank you very much.
Mr. Gomez.
Thank you, Mr. Chairman. If you talk to any family or American in this country, they know that healthcare costs are out of control because they see it every single month when they pay their medical bills or their premiums. They've seen it for years, but they also know that the system doesn't work, and so do a lot of elected officials. For far too long, you had a system that was trying to pass the cost, minimize coverage, and passing it from each, fighting amongst themselves. PBMs versus big pharma, health insurance companies, hospitals, physicians, everybody kind of jockeying to pass the dollar or the buck or the cost to somebody else, and at the same time making that fall onto the American taxpayer and to the consumer. We recognize that. In my district, in urban Los Angeles, I had 11 hospitals when I first started in 2017. 2 of them closed for a variety of reasons. And then we have other ones that are teetering. But I also have LA County General Hospital. I also have Good Samaritan. I have a lot of hospitals, and hospitals that do good work, that are trying to take care of their patients. So I recognize that pressure. But I recognize that things weren't perfect. The costs were still increasing. And we didn't have Congress didn't necessarily have a plan to deal with it. So when the Republicans take over, what's their plan? What's the first thing they do? Is they pass the one big beautiful bill that cuts almost $1 trillion out of Medicaid, that really impacts every individual in this country if they know it or not. It also hurts hospitals that have a lot of patients that are on Medicaid. And then they let the ACA subsidies expire. Just, if we look at it, who's getting hurt? Seniors, when it comes to accessing home care, children with disabilities, women who won't get reproductive health care coverage that they need. And in this country, 40% of all births are covered by Medicare. And the highest maternal mortality rates are 9 out of the 10 top states are Republican, who never expanded Medicaid. And then they go and they cut the ACA, or let the ACA expire. So you have a situation where the healthcare crisis in this country is getting worse. But what did the Republicans do? Their first priority was not to take care of the cost, the affordability cost. Their first priority was to pass one big, beautiful bill that would jack up the deficit and debt by $4 trillion, cut $1 trillion from Medicaid, $200 billion from SNAP, and they made it worse. So if now they have a priority, their priority is now trying to make excuses on what kind of plan that they have to address the crisis that they made worse. If there was a fire when it came to the healthcare affordability in this country, they put gasoline on it. And now they're saying that they're the firefighters to help deal with the problem. And I think that is completely wrong. We know that because the ACA subsidies expired, 24 million Americans are paying higher premiums. 15 million people are going to lose their health care. People are seeing premium increases as high as 280%. And here's the thing. It's also on top of every other affordability issue: housing, energy, childcare. And as somebody who grew up without health insurance, I know what parents do when their kid gets sick or injured. They want to wait to see if their child or their family member gets worse or they get better. When I was about 7 years old, because my parents wanted to see if I got better, I ended up getting pneumonia. It was so severe I had to spend a week in the hospital. When I broke my leg in 9th grade, or my ankle in 9th grade, my parents had me ice it not for 4 to 5 hours, for 4 to 5 days before I had to go and get it checked out because it was not getting better. So that delayed care is going to only make people go to the emergency room where it's the uncompensated cost. So we are in a crisis. But the priorities for my Republican colleagues were never to address this crisis. And even now, it's really as a political stunt to have something to show for the midterms, that they actually care. And the way they're talking is a little confusing because they have no concept of a plan, no plan, and they don't even know if they believe in private care, public care, if they believe in nonprofits. They're all over the place because they're not being truthful on what they actually believe. And they believe that the American taxpayer should not be involved in the delivery of care or involved in health care at all, and that every American should be on their own. And when they say that, they will have more credibility in the eyes of the American public. With that, I yield back.
Mr. Yocum.
Thank you, Mr. Chairman, for holding this important hearing, and thank you to our witnesses for being here and testifying today. Cost, quality, and access to health care is constantly top of mind for the Hoosiers that I serve. My district faces regulations in healthcare services, provider shortages. In addition to that, we also face constantly rising healthcare costs. Hospitals account for about a third of healthcare costs, and hospital prices have risen faster than any other part of the economy over the past 2 decades. Hospital prices are not exclusively responsible for the high cost of healthcare in the Hoosier State and across the country, but they definitely play a significant role. High hospital prices lead to higher health insurance premiums, placing financial stress on patients and employers that provide those benefits. Dr. Donley, New York-Presbyterian Health System is a tax-exempt system with 11 hospitals located across the New York metropolitan area, including multiple facilities in Manhattan, Brooklyn, and Westchester. Despite operating in a densely urban area, New York-Presbyterian reclassified, meaning your urban hospitals are counted as being rural under federal health care programs. Being reclassified allows you to take advantage of programs designed to support our vulnerable rural hospitals. Do you think it's justified that hospitals in New York City are reclassifying as rural providers in order to utilize programs designed to support vulnerable rural providers?
Yeah, thank you, Congressman, for your question, and thank you for your advocacy of rural hospitals. Rural hospitals are critical to the health in this country, and it's critical all of us focus on making sure they remain strong. We do not, in New York, consider ourselves geographically a rural hospital, but under CMS, we are designated as a rural referral center. And we are proud of the role we play in supporting rural healthcare as a rural referral center. We treat thousands of patients from rural America each year when there's nowhere to turn for that patient or for the doctor that's taking care of that patient. We also train 2,500 residents each year. 65% of those leave NYP, go across the country in places such as rural healthcare and help support rural healthcare.
Would you support Congress closing the rural designation loophole?
I'd be happy to work with you and have our team talk to you. I think it's important that we also, as we look at strengthening rural hospitals, we also maintain strength in urban hospitals. There's a shortage of 86,000 physicians that we will see over the next 10 years. And I think in regards to GME slots, the answer isn't urban versus rural. The answer is more GME slots.
Yeah, thank you. And large parts of my district are heavily rural, and our rural providers certainly do work tirelessly. They work every day to serve their communities and ensure access to Hoosiers that live in rural communities. Estimates show that administrative costs in our healthcare system account for between 15 and 25% of healthcare spending. Mr. Hazen, are there specific federal regulations that you see as drivers behind the high administrative costs facing hospitals today?
Thank you for referring to administrative costs, a very important issue and one that we believe there's opportunity to lower the cost of the system, which should translate downstream to lowering cost of purchasing health care. So regulation modernization, as we spoke to earlier, is an opportunity. There are huge numbers of regulations that get layered upon layers of regulation. We have conflicting regulations across different states, which produce administrative difficulties as well. And then I think in the commercial market, there are opportunities administratively as well that may be enhanced by certain regulation standards that the federal government imposes. So yes, thank you.
And Mr. Hazen, just as a follow-up, in your opening statement, you talked about how there are conflicting federal regulations for hospitals. Can you give some examples and maybe expound a little bit on the conflicting federal regulations you see?
If I understood your question correctly, Congressman, the conflicts exist between certain state requirements and federal requirements, and so we have to balance both. There could be opportunities to harmonize some of those. We understand that states have the rights to do regulatory things, but nonetheless, there are opportunities, we think, in common areas to consolidate certain regulations and create a little bit more efficiency for the system.
Right. And do you have any specific sets of regulations that you'd like to see us roll back or modernize?
Well, these are state-based, and we mentioned this.
Are there any federal regulations, and for many of you, are there any federal regulations that you think that we should modernize or do some work on that would help lower your cost of healthcare delivery?
We would be glad to bring some ideas forward. Thank you.
Thank you. Mr. Donley?
We spend $120 million on physical and cybersecurity. I think regulations helping to keep our workforce safe would go a long way. These people, as has been mentioned many times by the committee members here, are critical to providing care across this country. I'd appreciate the support of helping keep our workforce safe.
Great. Thank you. And Mr. Chairman, I yield back.
Thank you. Mr. Bean.
Thank you very much, Mr. Chairman. Good afternoon to you, and good afternoon, Ways and Means, to our all-star panelists. Welcome. We can all agree that housing prices have risen significantly. We can agree that childcare costs a lot more than it used to. And I think everybody knows that college tuition has risen so much, it's just unfathomable how much it's risen. But wait, hold the phone, shut the front door. There is a new heavyweight champion of rising prices. It's the hospital industry. And I got the tape right now. Let's show the screen. It's not from Bean. This is from the Bureau of Labor Statistics that has charted all industries. How have you risen your prices? And this top line is not the outline of Mount Everest. It's the outline of the price curve for hospitals, how much you've risen. In fact, I think the person that invented the phrase, "this is off the charts," probably was looking at the prices that hospitals charge. Now, all that being said, we need you healthy. We want your industry to be healthy. There's 330 million plus Americans that depend on you to provide the quality care that they expect. The federal government, we pay most of the bills, and so we want you healthy. So we've tried to work with you. And you said, give us tax-exempt status, give us rural designation. And what did you do? We got less charity care, and you raised your prices. We said, you said, pay us more money because when we do procedures in the hospital, because you said, we have to support an ER, an emergency room that loses money. So we help to support that. What did you do? You now build freestanding ERs on every street corner, at least in the free state of Florida, and you raised your prices. You said, let us consolidate, let us share overhead, and we can be a healthy industry. What did you do? You invented something called a facility fee that when you buy a physician practice, you charge more, and you raise prices. So what do we do? Where do we go? How do we believe anything you said? How do we restore trust in an industry that we've given you every chance there is, yet this, Mount Everest, is where we're headed? Any thoughts? How do we build trust? As you're thinking about it, maybe you'll say, and I've heard it here today a couple of times, the ACA, we want everybody to have coverage. Funny you mentioned that, because right around here, 2010, we passed the ACA. Everybody gets coverage, and that surely would make the difference. That's when rocket fuel was added to that price line of where everything shot up. It seems the more money we put into hospitals and in that industry, the more you raise prices. Where did we go wrong? Where did we go wrong with the ACA, and why didn't that honor the promise of bending the cost curve down? We thought this thing would peak right there, yet it still goes up, and there's no stopping it. Anybody want to jump in with what did we do wrong with ACA, and why didn't it bend the price curve? Dr. Waldrum, welcome. Jump in, my friend.
Well, I think that we do have a math problem, and I wouldn't say that anybody did anything wrong. I think you've heard from us that we need to have people have coverage so we can not cross-subsidize and have cost shifting.
Gotcha. We just can't.
And the hospital is not what it was last year or the year before. It's full of sicker, more costly people that
Dr. Waldrum, hold on one second, because it's funny. There's sicker people. We fell for that already, because built into Medicare, we pay you extra when you see sick people. We've already figured that out. And again, that also is read to everything else. Last year, you're not going to believe this, I got my knee done. I had a new knee put in. And show our next slide, our knee done. And I I still don't really know what it costs. But if there was a way that you could walk into the hospital and know what things cost, maybe it would look like this. At the Chick-fil-A, you know exactly what everything costs. Here's what I kind of mocked up of what it should look like. The only thing that I think is going to save us, and if you look at other industries, it's competition. And I want to salute Mr. Hazen. He understands competition. He says, get out of our way, we'll compete. But how do we have a competitive marketplace when the public doesn't know? How do we get you guys to be transparent? We've passed bills in the state of Florida. We've passed bills here. How do we get hospitals to be more transparent? And I am out of time. There's lots of questions. So here's our homework. How do we restore trust with the American people? And trust me, I am open. I would love to solve that. And I think everybody does. I look at my colleagues on the left and the right. We want to solve the problem. We have to solve the problem. But it can't be the answer, Mr. Chairman. Thank you for my extra time. It can't be we need more money, we need more subsidies. We're out. The American taxpayer is out. We can't do it anymore. So what can we do? I look forward to meeting with you later. And Mr. Chairman, thank you. I yield back.
Thank you, Mr. Schneider.
Thank you, Mr. Chairman. I want to thank the witnesses for appearing before us today and your patience and endurance for a long hearing, but we appreciate your perspectives. Across the community and communities large and small, rural towns and major metropolitan centers, healthcare, and in particular hospitals, are fundamental to the vibrancy and prosperity of our communities. Local hospitals are often the largest employer in their community, and everyone at some point in their lives are going to depend on quality hospital care. Just reflecting on my own lifetime, I know how blessed I am to live in a city, Chicago area, with many wonderful hospitals. Our children were born at Northwestern's Prentice Women's Hospital. I can't tell you how grateful we were for the quality of care when my wife had a serious medical complication during her delivery of our oldest son. 25 years ago, I had surgery to address severe spinal stenosis, threatening to leave me paralyzed at Lutheran General Hospital, now a part of Advocate. 17 years ago, I had life-saving surgery at Highland Park Hospital, now part of Endeavor Health, to address a staph infection that had risen to critical levels. Last year, my wife had successful hip replacement surgery at Endeavor Health Skokie Hospital, and just 4 weeks ago, as you saw me limping in, I had major foot reconstruction surgery at Rush Hospital. Now, I have to recognize how lucky I am to live in a community with so many wonderful hospital choices, including several safety net hospitals. Having access to these facilities during such crucial times is a privilege I do not take for granted. But here's the thing. Everyone in this country should have access to quality, affordable care from providers they know and trust when and where they need it. And I know our witnesses, and I'm sure all my colleagues on both sides of the dais can agree with that. What troubles me most, however, is that my Republican colleagues have had no problem accelerating the administration's attempt at weakening the American healthcare system while hospitals are already under severe strain. It's also noteworthy that the hospitals I mentioned have the names Advocate, Endeavor, and Northwestern, all examples of the consolidation we are seeing across the country. As the witnesses noted, consolidation is driven in part by necessity to survive. Access to quality hospital care is becoming more difficult and more expensive, irrespective of where we live. And again, as the witnesses have said, in rural parts of the country, hospitals are closing, but also in urban centers as well. That means too many expecting mothers are having to travel more than 30 minutes or even an hour to deliver their babies. Too many patients are waiting an average of 31 days to see a specialist, nearly a 20% increase from just 4 years ago. Too many ER departments have turned into overrun triage units with patients waiting for hours on end to receive care and be discharged. For example, Northwestern's Lake Forest Hospital in my district opened a brand new facility in 2018 with a beautiful ER. It was immediately overwhelmed. Last year, Northwestern doubled the ER capacity, and already demand exceeds that new capacity. So I appreciate the witnesses have emphasized three things we need to be focusing on: stable and affordable health insurance for all Americans, fair competition, and reduced administrative complexity. So with a little bit of time I have left, I want to ask a few quick questions for everyone on the panel. When a patient comes to your hospital, do you ever discriminate based on the type of insurance a patient has or doesn't have, Mr. Nazer?
We do not.
No.
Absolutely not.
Absolutely not.
That's what I expected. Next question, when an uninsured patient comes to your ER, does that uninsured patient put a burden on the hospital? Yes or no?
They don't put a human burden, they put a cost burden.
I meant cost burden, so thank you. Does it put a cost burden on your hospital?
Yes.
A cost burden, yes.
Yes.
All right. So, Mr. Hazen, I'll ask you, have you seen an increase in the uninsured population showing up at your hospital? And at the same time, have you seen a decrease of the population that was previously covered by ACA insurance?
Congressman, we just recently reported our first quarter earnings, and yes, we did see an increase in uninsured patients, 15%, and we saw an equal decline in patients who were insured in the health insurance exchanges, yes.
And there's a difference in coincidence and causality, but it is fair to assume that the fact that so many people are losing their insurance, whether it's because the Republicans took away Medicaid or because the ACA subsidies were allowed to expire, a 15% decline in those who have insurance and a 15% increase of those without insurance seems to be consistent. And I'll ask the last question. Well, I'm out of time, so I'm going to skip that. Let me just again say thank you. I know this is a hard challenge. We need to work together, both sides of the aisle, Democrats and Republicans, to make sure that Americans in the richest country in the world, everyone in this country, no matter where they live, no matter what income they have the greatest health care in the world. And with that, I yield back.
Mr. Moore.
Thank you, Chairman. I appreciate everybody, the witnesses, questions from across the dais up here. I want to reiterate, I think, something that our chairman was pointing out, that we've had, this committee in particular, but across Congress, across the country, and the administration as well, having several discussions on healthcare affordability. I think it's front and center to every American, and particularly over the last year. We've looked at it from an insurance angle. Different providers today, hospital systems, pharmaceuticals are always in a focus. What's clear to me is that if we're actually going to reduce health care for patients, it's going to take some give and take from all sides of the equation. And everyone here has a role to play in that. The constant, as the chairman said earlier, it's your fault, it's our fault, it's their fault. Like, the American people are getting sick and tired of it. They're sick and tired of the blame game, and they want to see results. One of the things that we like to talk about is competitiveness. This is a unique world because when you're obviously in the back of an ambulance and you've had a major accident happen, you're not in the ability to make a decision on, oh, take me to here, here, or here. You're going to go where that ambulance is going to take you, right? The call is made and everything. We get that. There's a different element to healthcare that doesn't exist in other markets. But it's still a very uncompetitive market. Even the dichotomy of New York-Presbyterian, right? You're talking about, in New York, we have an extremely competitive healthcare market, but also now there's an investigation from the DOJ on New York-Presbyterian for anti-competitive practices. There's no question there. I'm just highlighting there is this well, we do have some competition, but then there's accusations of it being completely anti-competitive, and we've got to figure out a way outside of that. It is one fundamental aspect to making sure that our healthcare can be affordable for the citizens of this country. Mr. Hazen, Mr. Lassiter, your companies operate a number of hospitals in competitive and non-competitive markets. I've had a chance to visit many and know the system well. Speaking broadly, would you say that hospitals in smaller markets, maybe your competitors who have fewer hospital systems, use insurance contracts to lock patients into one provider system, preventing them from shopping around? Is that a tactic that's often used, Mr. Hazen?
Thank you, Congressman. We do promote a competitive marketplace. Most of the states we operate in are non-certificate of need. We do have some certificate of need. Within our contracting strategies, we do not use that tactic.
Mr. Lassiter?
I would say it's the same answer, sir. Thank you for the question. We operate in varied environments across the country, 24 states. Again, some states have certificate of need, some do not. We operate in states where there is great competition, and we operate in states where there are organizations that have market power. We do not use the practice that you indicated as part of our contracting strategy.
Would you admit that insurer contracts are used to lock in patients to a one provider system? I mean, that is anti-competitive. How much worse is this going to get? I mean, that practice is happening. Maybe you're claiming that there isn't among your systems, but how do we get out ahead of that? How do we stop that from getting worse?
Congressman, I would say more competition creates opportunities to deal with that. Supply, if supply is constrained in a particular market, creates opportunities for choice. It creates opportunities for lower cost, convenience. All those factors can contribute to dealing with that particular issue.
Thank you. Mr. Lassiter, I'll just finish with one last question. Health systems invested over $1.3 billion last year in AI tools for clinical documentation and coding, tools that often don't change the care that a patient receives, but instead increases coding intensity and reimbursement. When you evaluate ROI on those AI investments, are you measuring success based on improvements in patient outcomes and efficiency or an increase in revenues?
When we evaluate investments in AI, we're evaluating it based upon a number of factors. We're first and foremost looking at, does it help us increase the quality and safety of the care we deliver to our patients? That's first. The second thing we look at is, does it improve the working environment for our caregivers who are burned out and we're focusing on helping them increase their resilience. We do not look at AI tools specifically to drive. I think you didn't use this term, but I would say upcoding and things of that. That's not our explicit goal. Our goal is always to code the clinical record accurately and appropriately.
Thank you. Thank you, Chairman.
Mr. Horsford.
Thank you, Mr. Chairman. I think it's important for us to remember how we ended up here and how we've arrived at this moment. It was a choice. It was a choice to pass a bill last July that some call the One Big Beautiful Bill. I call it a betrayal of a bill. It was a choice to give tax breaks to billionaires and to big corporations at the expense of hardworking Americans. It was a choice to cut $168 billion from nutrition assistance programs for people all across this country. And yes, access to food is health care. It was a choice to take $1 trillion out of the healthcare system. It was a choice, and now there are consequences to that choice. The consequence is evident in the lives of patients all across this country and in communities that we serve. It's the consequences in emergency rooms happening right now where someone's life is at risk. It's consequences that are showing up in hospital budgets. And Nevada leaders have warned that residents will, quote, feel the ultimate pinch, and that the fallout from these cuts will be pretty horrific. And Las Vegas University Medical Center is bracing for $45.4 million in annual losses, while Mountain View Hospital, owned by HCA Healthcare, is projecting an $18 million shortfall. Boulder City Hospital has already begun laying off about 70 workers, ending inpatient care and transferring patients elsewhere due to changes in the provider fee program. Make no mistake, these are likely just the first reported hospital job losses in my state alone tied to this one big, beautiful bill. Nationwide, Public Citizen recently found that 446 hospitals are at a heightened risk of closure or service reductions. That represents 69,000 beds, 6.6 million patients, and 275,000 healthcare workers that we depend on to provide this essential care. In Nevada alone, 4 hospitals have been identified as at risk, including St. Rose Dominican, DeLima, and Henderson, part of the CommonSpirit health system. Mr. Lassiter, I understand you may not be able to speak to the specific projections, but can you broadly speak to how the One Big Beautiful Bill impacts services that your hospitals provide? Briefly, please.
Thank you, Congressman Horsford. Would just say simply the impact of the bill for CommonSpirit is approximately $5 billion in lost reimbursement over the next 10 years. At its highest point, beginning about 2031, CommonSpirit will lose $1 billion in reimbursement that we currently receive.
Thank you. Mr. Woodhouse, will $50 billion in temporary rural funding make up for nearly $1 trillion in permanent health care cuts? Yes or no?
Well, no.
Thank you. Investing in the health and vitality of rural America is necessary and long overdue. I agree with the chairman and his passionate plea at the beginning of the hearing, but the reality is this fund, this Rural Health Transformation Fund, was not designed to replace or meaningfully offset the lost health care funding. If it were, we would see far greater flexibility to invest in workforce and direct patient care. Instead, much of the funding is geared towards building digital infrastructure, and while that has value, I've yet to see any technology that can replace doctors, nurses, and frontline providers, especially in rural communities like the ones I represent. And while rural hospitals are grateful for any support, they're also deeply concerned. They worry that program restrictions combined with limited state capacity will only make it more difficult. So, Mr. Woodhouse, will the Rural Health Transformation Program meaningfully help rural hospitals in my state? And how should families in these rural communities react when there are comparable or even greater resources being directed to high-profile presidential pet projects, international ventures abroad, and now a vanity project to build a ballroom at the White House?
Well, I think your constituents and constituents in rural America should be concerned. I mean, I was not a math major, but $1 trillion in cuts to Medicaid and a $50 billion rural transformation fund. The two are not comparable to one another. The Kaiser Family Foundation said they didn't believe a single state would gain more from the Rural Transformation Fund than they will lose from the Medicaid cuts.
Thank you. Just in closing, Mr. Hazen, I know you work closely with SEIU 1107, which represents nearly 20,000 healthcare workers and public service workers across Nevada. They recently, after 13 months of negotiation, more than 300 employees secured their first contract, one that strengthens recruitment and retention and delivers average raises of more than 12%. So I want to ask you, can you commit to engaging in fair, good faith contract negotiations in Nevada? And can you commit to ensuring that equitable wage growth for your staff across the healthcare system, including at Sunrise?
We thank you, Congressman. Sunrise is a great hospital. We do approach our contracting with that attitude.
Thank you.
Mr. Moran.
Thank you, Mr. Chairman. Before I get into my questions, I want to play a little bit of a cleanup here on a couple issues. First, Mr. Woodhouse, I want to come to you because I was concerned, Mr. Bean, when he was giving his statements and using his 5 minutes. I was watching you closely, and I was shocked and surprised by the fact that you were rolling your eyes during his commentary, and I clearly viewed you doing that. And I have to say, I was disturbed by that. He was talking about rebuilding trust in the healthcare industry. And here, one of our 5 witnesses were here rolling his eyes at the very things he was trying to engage in on a bona fide, reasonable dispute on differences between your position and ours. And I would just say, I don't think that's helpful to your position, to the things you're trying to advocate for here today. We want to have an honest discussion, and I certainly don't think that Protect Our Care hired you to come to Congress to roll your eyes at a colleague of mine when he is giving you statistics from the Bureau of Labor Statistics that are honest statistics engaged in an honest conversation. So I'd say next time, watch your behavior when you show up in front of Congress.
I don't think I was rolling my eyes at that.
You were,
I was
indeed.
not rolling my eyes at that. You're way more perceptive than I am if that's what you think. He was talking about increase in hospital prices. That's not my.
I'm talking about
that's
your
not my
reaction,
issue.
and you probably
so I
need to
would.
get-
so
you
I
probably
beg
need
to
to get more
differ with your
preparation
perception.
like Mr.
Maybe
Donley
you should be
over
the one to watch your behavior.
pardon me, sir, but you're here to answer questions from the United States Congress about how to fix the very problem that you continue to advocate for. You want us to double down on the failed policies of the ACA, and I'm amazed that my colleague over here, I'm not asking you a question, you can just hold your tongue for a second. I'm amazed that my colleague would talk about the difference between the 1 trillion and the 50 billion when the 1 trillion's waste, fraud, and abuse. We're talking about people that were not even supposed to be on Medicaid. And you're saying, we want to keep them on the rolls. We want to put more people on the rolls. We want to throw more money at it when only what we're seeing is the price is going up, as my colleague so aptly pointed out. I came here with a set of questions that now I'm going to have a hard time getting to because I can't believe that you're wanting to double down on the very failed policies that the Democrats have been leaning into for years. That even Hakeem Jeffries said a few months ago was a broken healthcare system. And that's what I used with the health insurance companies when they came here a few months ago as well. Because it's amazing to me that we want to keep doubling down on the failed policies. I also want to clarify this because before I get into my questions, I noticed that whenever members of the committee have asked the witnesses here today about why they deserve to be paid more than independent doctors for the exact same service, you all keep saying, quote, it's because we care for sicker patients. But let's make the record clear and accurate. Medicare already adjusts payments based on how sick a patient is, whether they are sick in a hospital or sick in a doctor's office, so that argument does not hold any water. And we're talking about why hospitals get paid more for the same service, for the same sick patients, just because their name is on the door, and that's what this committee will work to fix to lower costs for all patients across the country. I can tell you, I can attest to this in particular, and again, I probably won't even get to my questions today. It's amazing to me. I understand the issue of site neutrality. I'm from a rural district. I get that there are outlying entities that need to be supported, and a lot of those payments go to help support that at the end of the day. But I also understand that from one year to the next, I went to the same pulmonologist, got the same service in the same location, and from one year to the next, they were required by a hospital system, and all of a sudden I had an enhanced patient fee, a facility fee that I had to pay. Now, I can afford it, but many others cannot. And there's no reason, there's no added expense for that, except the law provides for that. And so that does need to be fixed. And I will also say in my remaining time in the last minute here, that this pain point is not just on you guys, we get it. It's PBMs, it's Medicare Advantage, it's health insurance companies, it's hospitals. It is the whole system, and it's working against the patient in every instance. And I don't get that. Actually, I do get that, because it's all about profitability, not just for the hospital systems, but also for the insurance companies, which we hit a few months ago as well. That has to end. The self-serving nature of what we're doing in this industry absolutely must end. You have to do what's right by the patient and not try to exercise strict construction of a statute to go against the spirit of the statute like we're seeing in non-rural medical facilities in the middle of New York City that are claimed to be rural hospitals. It might meet the letter of the law, but it's not the spirit of the law, and the person that loses on that is the patient. And our patience is waning on that. And Mr. Chairman, I would suggest that this committee take a holistic view and rewrite this entire scenario so that we can let the free market determine what's going to happen. We can let patients have more access, more quality care, lower prices, and all of you and all the insurance companies and all the PBMs and all the other entities out there that are gorging profits to the detriment of the patients, you begin to lose and the patients begin to win. With that, I yield back.
Mr. Swazi.
Okay, thank you, Mr. Chairman. I appreciated your remarks earlier today when you talked about we need to work together, Democrats and Republicans. I think we need to do a lot more of that to try and find answers to these very complicated problems. This is a really complicated topic. I mean, there's just so many different factors. I hate the blame game stuff. I really think it's so inappropriate because it's so many different factors that are involved here, from urban versus rural. I looked it up just a few minutes ago. There are 1,800 rural hospitals, 3,300 urban hospitals, according to the American Hospital Association. There are 3,000 not-for-profits, 1,200 for-profits, 900 state and local, 200 federal, and 656 psychiatric hospitals. So it's a very complex, diverse environment that we're living in. I had some friends here from 32BJ. They're kind of act like insurance companies because they're self-insured. So they're upset about increased prices that they have to pay as a union because of self-insured. But affordability is a problem for everybody. It's the number one issue in America right now. Affordability is the biggest issue in the country, and hospital costs and health insurance costs are a big part of that affordability crisis in our country, increasing costs because a bunch of people got whacked when they lost their premium tax credits in January of this year. When people lose Medicaid, it's going to hurt a lot of people. It's going to hurt your hospitals. It's going to hurt the healthcare system. And there's going to be less people insured. When there's less people insured, less people in the risk pool, then everybody's insurance rates go up. Okay. So I want to ask I want to just ask some basic questions. And I want to offer to meet with you and bring in experts from insurance companies, from pharmaceutical companies, from PBMs, from doctors. We got to come up with some real answers here. Not these one-off things. We need something comprehensive and not finger pointing. So, quick questions. Mr. Hazen, you represent a hospital, for-profit hospital. Do you make money or lose money on Medicaid?
Congressman, did you say Medicaid? I didn't hear you.
On Medicaid, do you make money or lose money?
We lose money.
Mr. Lassiter, do you make money or lose money on Medicaid?
We lose money, Congressman.
Mr. Donley, do you make money or lose money on Medicaid?
Medicaid does not cover the cost of care.
Dr. Waldrum, make money or lose money on Medicaid?
Lose money.
Okay, so you're 3 not-for-profits, you're 1 for-profit. What about Medicare? You make or lose?
We like to refer to ourselves, Congressman, as tax-paying, but nonetheless, we make a little bit.
Okay, how about you, Mr. Lassiter? Do you make money or lose money on Medicare?
Medicare generally does not cover the full cost of care provided to CommonSpirit.
Dr. Donley, you make money or lose money on Medicare?
Medicare does not cover the full cost of care.
Dr. Waldrum?
We're price takers and we lose money on Medicare.
So when people show up and they have no insurance at all, do you lose money on that or you make money on that?
Lose money.
Dr. Donley?
We lose money.
Dr. Lassiter?
We lose money.
Mr. Lassiter? Mr. Hazen?
Lose money.
Okay, so you're losing a lot of money from Medicare, Medicaid, and people coming in with no insurance. So how do you make up for the money that you lose from Medicare, Medicaid, and people not having insurance? You make it up by getting more money from the private insurers, which upsets the insurance companies, so they go after you. It upsets the unions that are self-insured and other self-insured businesses because they've got to pay it. But that's understandable. That you also make up it by doing philanthropy. Do you have like charity dinners and things like that, Dr. Waldrum?
Yes, we do. 75% of our patients are Medicare, Medicaid, or uninsured. And so the only way that we can make it is through commercial.
Do you do philanthropy, though?
Yes.
You get philanthropy, Dr. Donley?
Yes, Congressman.
Mr. Lassiter, you do philanthropy?
Yes, we do.
How about you, Hazen? Do you get philanthropy in the tax-paying hospital?
We provide charity care, yes.
But do you get philanthropy from the private sector?
No, Congressman, we do not.
Okay. Do you have an endowment, Mr. Lassiter?
We have reserves, so I guess the answer would be yes.
You can invest that money and make some money off of that?
Correct.
Dr. Donley?
We do.
Dr. Waldrum?
Correct.
Okay, so you have to figure out how to make up for the losses you have in the other area by doing these other things. And some of the things that you do, I would suspect, are what has been referred to as gaming the system. It's all perfectly legal, but you're trying to use the existing laws that are incredibly complicated. You do something over here, and it pops out over there. And you do something over here, and it pops out over there. And so you're trying to figure out, how can I use the law in order to bring more revenues into my hospital, either for-profit or not-for-profit, to make up for the losses I have from my Medicare, Medicaid, and non-insurance patients. So it's very complicated. So I want to ask each of you if you'll commit to work with me, and I'm going to ask the chairman if he'll help me with this as well and get me some Republicans, and sit down and let's figure out, let's bring in a bunch of experts and talk instead of like yelling at each other and say, what can we do to make the world a better place to live in by improving our health care for the people that are suffering from these burdensome costs and have better health for them? Would you help with that, Dr. Waldrum?
Yes, we look forward to that.
Dr. Donley, would you help with that?
Yes, I would.
Mr. Lassiter, would you help with that?
We look forward to it, sir.
Mr. Hazen?
Yes.
And Mr. Woodhouse, I need your help on this too. I didn't ask you questions because you don't run a hospital, but I know you're an expert in this area.
Absolutely.
We'd love to have
I'm there
your help.
for you.
Mr. Chairman, thank you very much, and I yield back.
Thank you, sir. Before I adjourn the hearing, I want to enter into the record some information. We've heard a lot of comments and testimony in regards to 15 million people that was thrown off of health care because of the big, beautiful bill. We've also heard the $1 trillion that is being cut to health care. And so I just want to give the exact facts from CBO, the Congressional Budget Office, which is being cited. 6 million of the people of the 15 million are able-bodied adults without dependents who choose not to meet the modest Medicaid work requirements. So they just choose not to work for Medicaid. So that's 6 million people, which adds up to $325 billion. 1.4 million are illegal immigrants, and 3 million are people already ineligible for Medicaid and simply haven't been removed from the program. That adds up to $200 billion. And then there's $350 billion worth of provider tax loopholes that states were using that was cleaned up. And then the remaining 5 million people are supposedly due to the expiration of the expanded Obamacare tax credits, which the Democrats set the expiration date. With that, I'd like to thank our witnesses for being here today for 4.5 hours. So we appreciate that. Please be advised that members have 2 weeks to submit written questions to be answered later in writing. Those questions and your answers will be made part of the formal hearing record. With that, the committee stands adjourned.